Hello, check, check. Hello, text. Hello, hello, test 1, 2. Hello, test 1, 2. Test, check, check 1, 2. Hello, test, check. Hello, test 1. Hello, test 1. Hello, test. Hello, test 1, 2. Test. विक्रांत पीपीटी डालो भाई. पीपीटी हाँ. पीपीटी डालो सेंटर. नहीं केस नहीं. प्रेजेंटेशन. कोई भी प्रेजेंटेशन. ठीक है. ओके. थैंक यू. विक्रांत. ओके.
Thank you very much, sir. No problem.
No problem. ഭക്ഷണം കഴിക്കാൻ പറ്റുന്ന
ഭക്ഷണം കഴിക്കാൻ പറ്റുന്നുണ്ട്. കേട്ടോ?
ഓക്കെ
കർണാടക.
കർണാടക രണ്ട് താങ്ക് യു
താങ്ക് യു സാർ. താങ്ക് യു.
ഓക്കെ
ഓക്കെ.
ഇറ്റ് ഇസ് ഓക്കെ താങ്ക് യു നന്ദി
താങ്ക് യു വെരി മച്ച്, സാർ. നോ പ്രോബ്ലം.
നോ പ്രോബ്ലം. ഭക്ഷണം കഴിക്കാൻ പറ്റുന്ന
ഭക്ഷണം കഴിക്കാൻ
मैं बहुत शुक्रगुजार हूँ राकेश जी का, जिन्होंने इतना अच्छा साउंड सेटअप लगाया इस कॉन्फ्रेंस के लिए और अपने संपूर्ण ध्यान जो है पूरे के पूरे दिन फेडर्स पे रखा. कोई भी माइक जो है ऐसा नहीं हुआ कि टाइम पे ऑन ना हुआ हो. अपने काम के प्रति वो हमेशा ही सजग रहे हैं और मैं आग्रह करूंगा राकेश जी से कि वो प्लीज़ मंच पर आएं और दो शब्द बोलें. This is how you take the mic. ये नहीं हेलो कुछ भी बोलो यार.
Take.
हेलो हेलो चेक 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 हेलो हेलो पोडियम से बोल रहा हूँ हेलो हेलो चेक 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 चेक
Excuse me. So if we end 15 minutes late, there's a live case scheduled to start at 10 o'clock.
That's a 1 hour live case, sir. Like that.
But they're going to be ready at 10 o'clock.
Yeah. We will just coordinate. Try to make it 10:10.
I mean, they have 2 hours to plan, so that'll be okay. But they need to know.
I think maybe we'll be able to catch up sometimes here. Like there was 10-minute lectures and there are 10 minutes for discussions. From 9:15 to 10 o'clock. There are only 4 lectures. And the problem is that the live case center is also not ready right now.
Okay, well, that's a problem.
They will take 15 minutes. Like here you have 4 lectures.
So we get rid of them, so no discussion.
So like 1 or 2 questions and
No discussion.
I'll just update you on that 10 o'clock live case.
Right, you should call Japan. Call
Yeah, just now
Yamashi.
we're calling you, right?
So, my session is supposed to start at 1, okay? There was currently 4 people in the audience. And it's supposed to start with live cases, the backups is ready. It's like, why do they, I mean, this is like normal here. Sunday morning, 8 o'clock. Yeah, well, it's okay, we'll start 15. Then at 10 o'clock, there's supposed to be live case transmissions from Onami, Japan. And they will be ready on time. So also, yeah, you know. That's the way it is. Talk to you later. Normal, bye.
So, just in case we become slightly delayed, then this lecture may be postponed post live case. The other. Just in case we get delayed, we can't finish it in time.
We may have to cancel that whole, both of those talks.
No, not really.
No. He may not be able to stay, okay? You have to understand, people have other things to do. Okay? Sorry. 8 o'clock, we should be starting at 8 o'clock. Or else you build in an hour of flexible time. You can't just move people around here and there. Also, by the way, this is not good. This is barely good enough. If I'm giving a talk about pictures, and I have to point to pictures, I can't do that.
We just find out that then we will get another one.
No, this will never work. It has to be a pointer on.
On the screen.
on the screen. I mean, how can I talk about pictures when I can't point to pictures? Well, I have to give a lecture about images, pictures. How do I point to the images?
I'll get you a pointer.
There's a pointer here. How can you see the images? You can't, it's not good enough.
Should we move to one? Sir, this is LED screen, so unfortunately the pointers only work very limited to the LED screen.
Right, there should be a pointer on the screen here.
Yeah, but this is not exactly at this time.
I can't give my talk.
Okay.
I mean, I'm gonna give a talk about pictures and I can't point to pictures. It's like giving a lecture about art and you can't point to something.
But we have your feedback, so we will build the systems like this going forward. The first
And
time
this is not good enough.
okay. high volume center. That's PGI Chandigarh. You been there before? You been to Chandigarh before? Oh, that's good that you have planned Chandigarh this time. You know one thing that's known as a beautiful city of India?
So let me tell you my schedule.
Okay.
For the next week, I will have, I might as well have my eyes closed, except for the hospital. The schedule is totally, totally, totally jammed from waking moment to when I go to sleep. I mean, either that or I'm on a plane, or checking into a hotel, or in a taxi cab, or in cars. I looked at the schedule and I said, "Are you guys crazy?" "Oh, no, no, we'll have plenty of time." I said, "Right." And that's before they add things, which they always do. So
They had some more things.
they
Okay.
always do. I mean, I get to see a little bit. I did this in October, and I went to Kerala and I saw Kochi. And I actually saw maybe 1 hour of Kochi.
Oh, for tomorrow, when are you going to Chandigarh? Are you going tomorrow morning?
Tomorrow morning.
And when are you coming back? Day after that?
No, no. We go to another city, I think, early Tuesday morning. Yeah.
You're
Yeah.
coming back tomorrow morning, tomorrow evening.
No, 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 no. I have, I land in the morning.
Okay.
I have an afternoon and evening symposia.
Yeah.
I stay overnight and I leave Tuesday morning.
Tuesday morning.
Yeah.
So you have about one day in Chandigarh.
Right. In the hospital.
In the hospital.
Good morning and welcome to today's morning sessions. So I begin the today's morning session of complex intervention conclave, and may I welcome on stage all the chairpersons and moderators to take the seat and begin the session. Thank you.
So,
Hi guys. My name is P. Yadav.
so are they ready to go?
Yeah.
Yeah, they started. I don't know whether the audio is on.
Is the audio on?
So, can we have the cath lab in front of us? Or that's the center two, so that's not the first. Is Chennai ready to go? So, excuse me, can the producer come up? I think we should go to the second case at 8:30 and not show the first case.
That's fine. Read it, that's it. Could you have a cup of tea then? Do you care for a drink?
ഡേ ഹിസ്റ്ററി പറഞ്ഞു. കേട്ടോ?
So we're going to.
റെഡി
go-
റെഡി
Great.
യു ആർ റെഡി.
Good morning.
ഗുഡ് മോർണിംഗ്.
Morning.
ടെൽ ദ ഹിസ്റ്ററി.
Okay, good morning. Our patient is a 60-year-old male. It's a case of down hypertension, chronic stable angina, treadmill positive. Underwent angio some 4 months back, which revealed two-vessel disease, circ disease, and proximal artery CTO.
അവ എവിടെ പോയി?
Already underwent PCA to circumflex and OM. Now we are planning to do an RCA CTO. Just please show the angio. Proximal artery show a long segment CTO with an ambiguous sense and a bridging collaterals with a JCTO score of 2, around 2.
So
His LV function is good and renal function is okay.
we see the angiogram.
Okay.
Yeah. Can you see the angiogram now?
Yes, we can.
So this is the today's angiogram. We did a bilateral injection, and it shows that probably a bridging collateral osteoproximally. We did not try anything. We just searched for the septal collaterals and even the epicardial collaterals. We thought when you are coming on live, we will try antegrade. If not successful, we will go retrograde.
Okay, sounds like a plan.
So we actually,
So
Any
before-
comments?
Before you start, can we ask your producers in the room to get rid of the small insets? We see you and we see the IVUS on the lower left-hand corner, but they are covering up the right coronary.
can you tell the എൻ്റെ ഫോട്ടോ ഇല്ലേ അത് താഴെയാക്കാൻ പറ. ഐ വാസ് കട്ട് ചെയ്തൊരു ഫോട്ടോ താഴെയാക്കാൻ പറ. എന്തുകൊണ്ട് മണ്ടപ്പരാന്നൂടെ?
Do you understand what I'm saying?
Can you just tell them? No, just. No,
Yeah,
I
yeah.
understood. I'm just conveying the message to those people.
Okay, thank you.
No, cut, totally cut. മനസ്സിലാവുന്നില്ല.
No, that was
Okay,
perfect.
okay.
Now the
Okay,
second
now it
one.
is okay?
Now also get rid of you, sorry. We like seeing you, but we need to see the artery.
Okay.
Perfect. Thank you.
Okay.
Just go to the. Small check. 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 Check.
There is an observation.
Now
that
we
the
are actually trying with
patient's
the-
name should be deleted.
Yeah, I don't know
For
if you,
confidentiality, it is not
Our
allowed.
patient's name should be
perfect.
deleted.
No,
Okay.
it's still there.
Patient's name delete. Name delete.
We are actually trying with a microcatheter that is fine cross with a cyan black wire to enter the vessel. Then we will try with an XTR.
Right, sorry. So start one by one. What equipment are you using? What is your guide? What is your wire? I know you said there was a fine cross supporting the wire, but which wire are you using?
We have a seven French EBU catheter on the left side and a 7 French JR 3.5 on the right side. We see some small microchannels in the RCA, right coronary artery, and with some bridging collaterals. So we decided to take a microcatheter up to the tip of the proximal part of the occlusion, then shift the wire into a XTR, which may cross. If not crossing, we may upgrade the wire to a different level. And if it is not possible, we will go retrograde. We tried septal channels during the last 20 minutes, but no septal channel is connecting. One epicardial collateral is connecting that I was keeping as a last resort if I am unsuccessful antegrade.
Okay.
So if you want to see the next projection, this is actually the connection. Septal channel connections are not very clear. There is no connection directly, and the small connection distally is to the acute marginal, not to the PD or PLB. Next. We have taken another injection, already stented patient to the circumflex. There is a connection from the epicardial collateral from the stented segment down, but there is a tortuosity distally. So probably I may be in trouble to take the wire. That is an only epicardial collateral left out. Next. So we tried surfing for these septal collaterals. This is actually, we took a Caravel catheter, just took a tip injection. It is not really connecting. Next. So we search for the distal vessels. Again, it is not. Next. So this, we went into the septal, this is actually the septal tip injection. This part is not connecting. So we tried with the first proximal branch. It went down, but it ended into a blind pocket. So not possible. So this is a story now. Any comments?
No. I think you.
Now we have taken a.
No, I think you did a reasonable approach to look for likely connecting vessels. So let's hope you can get through antegrade.
I personally feel that. But before that, I searched for the septal collaterals, because if at all I'm failing, I should make it a way for that.
So I know this is a live case, but would you have done the same thing
Yeah.
clinically, searching for the collaterals before you try antegrade, or would you always try antegrade first?
Definitely antegrade first. Actually, this is a fine cross microcatheter in the RCA proximal part. I am trying with the XTR wire. Probably I may have some micro channels there. I will try.
Nac, stupido, stupido. Stop, pedo. Sale.
This is the XTR wire, which is, we are just trying to create a channel. I don't know whether it will be crossing.
Do you think you have enough guiding catheter support?
I did not deliberately, I did not take an Amplatz catheter because the osteoproximal part is also mildly diseased. I don't want to create a dissection in the osteoproximal part. So if at all I'm not getting a support, I have a branch, is a cornus artery coming up. I can put a anchor balloon and support. I'll try. If it is not possible, I put an anchor balloon in the side branch and get a support.
Okay.
Small check. City. Probably I am in the track, that is what I think, I don't know.
I mean, it does look in this projection as if you're making little bits of progress. At some point, you might want to do an RAO and see whether you are still, within the confines of the vessel.
RAO.
One of the problem with the RAO projection in right coronary artery, actually your movement of the eye will be a problem. It will be moving too much. So there will be a distraction on the eye and it can create some problem. But in between, we can go and check it whether we are in the right track or not.
But this does look promising.
Looks promising, sir, but
You don't always know.
can take an injection and see.
Yes.
Looks promising.
Yeah.
It's worth noting his hands and how he's working the wire back and forth, back and forth, back and forth.
Saline. Drop in into the drop. LTG stop alle. Stop ആയി. Saline മാത്രം. BP കുറവാണ്. അതെന്തോ? സ്റ്റാർട്ട് ചെയ്തിട്ടില്ല അത്. സലൈൻ അപ്പറാൻഡ് വാട്ടർ. സലൈൻ അപ്പറാൻഡ് വാട്ടർ. BP കുറവാണ്.
Can you just do a small check and see?
Yes.
Can we do in another angle,
RAO.
which is RAO?
RAO.
You're out of the track.
Yeah. So in the REO view, it looks like you're in a false lumen.
Yeah. Go back.
Yeah. Up. I mean, it looks like it left at the bifurcation.
Just give me a blue wire. Can you get cyan black in the road?
So are you changing the curve or you're also changing the wire?
I'm changing the wire because I don't think that wire will cross. So in the meantime, I'm just putting a wire into the cornus artery to get some support. Okay. Just give me first again the wire to take the same wire. No. Give me a Gaia second.
So if we heard correctly, you're now going to use a Gaia second.
I am going to use a Gaia second. I kept a cyan black wire in the side branch, acute marginal. If I decided not to inflate now, because even the wire will give a support. Small chick. Can I take one more injection and see? Can you go back to the RAO card? RAO, plain RAO. Small check. Just keep that. I'll just go in this angle. The distal cap is the toughest prop. Even that time, the proximal cap I crossed easily by the XTR. But the distal cap I could not cross. Probably distal cap is very tough. I hope it may work out. I don't know. Check. Check.
Yes. See, the movement is.
Can go back to iliocranial and see. Plain ilio. Cine.
It looks like you're in the acute marginal.
Yes.
Yes.
Look like I'm in the
Marginal branch.
I'm in the acute marginal. Will remove the wire and redirect.
think you're still in the acute marginal.
Actually, I just wanted to push my wire into the acute marginal. If I am crossing, I can even take a close side and cross into the vein vessel. I don't want to damage the chance of, if at all I'm in the acute marginal also, I'm happy because that is distal to the occlusion segment. Segment is so tight, even the microcatheter is not crossing that part.
So what are you trying to do now?
I'm actually trying, there are two things you can do now. You can actually keep the wire here, take a small balloon, try to push the balloon down, and in small inflation, then push the wire down and trap the wire out and take it out. That's one portion because I am definitely in the acute marginal. That is 100%. So,
it seemed the approach that you said, I would agree with that, and I would have done the same thing, that trap this wire and take a very small balloon, 1 millimeter, 5 millimeter in length, and I strongly feel it will go up to the acute marginal, open up the balloon, and then that would give a room for the wire to get manipulated into the vein vessel.
that is what I was thinking because actually now the problem is even the microcatheter is not pushable and it is not going down. So I was trying to push the microcatheter down, it is not going down. If it is a microcatheter gone down, it was easy, then it was easy. But it is not possible. It is not at all moving down.
You know, another possibility.
Otherwise, one option is to take the wire.
So one of the possibilities is leave the wire here, bring down
Sir,
another
please.
wire alongside, and see whether you can direct it would then be a third wire into the true distal right coronary artery, just leaving this wire where it is to hopefully block entrance into the acute marginal.
That is also one option because I still don't know whether that space will allow one more wire to go down.
Difficult to get another wire to go down.
It will be so difficult because that distal part is looking very, very tough. Now I am removing the wire. I am actually going to do a balloon trap technique. I remove the balloon, microcatheter. Okay, balloon. We are trapping because the other wire is there. There's through that wire itself we can trap it. നല്ല balloon എടുക്ക്. സമയം സംഭവിക്കുന്നു. I'm actually now trapping the microcatheter down, taking a balloon down, balloon keeping distal to the microcatheter. Now the balloon came down. I'm going to inflate at a high pressure,
Okay.
15, 18, 20. Take it out.
Just to show a case in point, so take every step backward.
Now I trapped and taken out. So the balloon also taken out. Give me a 1.25 millimeter Tasuna wire. You're going to take a Tasuna 1.25, the shortest balloon available in our place. There are 1 millimeter balloon also available. ഏത് വയറിനത് ഷുവർ ആണല്ലോ.
But then time is not enough. So are you going to take a balloon now?
I've already taken 1.25 balloon. It is actually, I'm trying to take the balloon down. I don't know whether it will come down. I'll try. This is 1.25 millimeter balloon into the proximal part of the occlusion segment.
Now here you would need a lot of support to the guiding.
Can you just give me a 2 millimeter balloon for the side branch? 2.9 or 2.12, anything is okay. Pare. It's okay. Give me a 2 millimeter balloon. 2. Probably a lot of severely fibrotic lesion, I hope. Wire came out.
So what is the length of this balloon that you have taken now? I think a shorter
12.
balloon. Hmm? 12?
Just keep pushing. Okay. Go for 5, 6, 7, 8.
Nominal.
Okay. Okay. Deflate the balloon. Go. Go inflate the other balloon.
Slipped.
Deflate.
Can you tell Dr. Pratap what are you trying to do?
15. I'm actually trying, in the meantime I pushed the wire into the acute marginal distally, you saw that. So I personally feel that, but the problem is actually my trapped wire is, balloon is not sitting there. Deflate. This is a trap balloon.
Pressure. So 8.
Now, as Dr. Gary told, the initial part, whether it is good to have another real supporting guide catheter. That now really is the challenging part of my 15.
Slippy.
I'm actually just inflating and pushing the balloon down. Inflate, deflate.
Slippy.
Inflate, deflate. Inflate, deflate, inflate, deflate. Inflate. I just went a real good distance down, but not the distal most part.
You see, the problem here is that once you inflate the balloon in the proximal part, then you lost the profile of the balloon.
Deflate.
So go as deep as you
That's
can
a problem.
and then start inflating. But if it doesn't go, then obviously with the inflated balloon once in the proximal part, it may become all the more difficult to get it down.
One thing we can do is actually we can take a Corsair and create a channel and then go down. That's one option left out. Unlike the fine cross and all, Corsair can be screwed down and go down. That's actually one way of going down.
Another option.
Because already we crossed the CTO segment.
Well, another option is, of course, requires a lot of experience, expertise, and little dangerous also. You change this wire with a rota wire, and do a rota into the acute marginal branch, and that would show you the main vessel.
It may not be necessary to take,
That is little.
you know, it may be
got
enough
I
to
think,
do
as
proximal
Gary told, there is
bifurcation.
one more option left out. You can take another wire and go into the right place. Can you give me a Gayatri?
I mean, so, you know, so there are a number of options. Let's just sort of list them. Option number one, we already tried. He already tried, which is a small balloon to try to dilate proximal to the bifurcation. Option number two, he just suggested the parallel wire technique, leaving this one in the acute marginal, trying to get a second wire alongside this, which may be tough, into the true distal right. Option three might be to use something like a Corsair or a Turnpike, where you can sort of screw open a channel. And then there are devices such as excimer laser, rotational atherectomy, and so on, that have the potential of at least getting you through that proximal portion. But, you know, it depends what you're comfortable with and what you're familiar with. So you unfortunately have only about 5 minutes. We'll give you an extra couple, but that's the allotted time. Then we have to get on with the program.
Where is that? I will try. The first option, I'm just taking another wire.
Yeah, see, this is pretty good.
Check. Yes, I crossed.
Gayatri wire.
So anyway, before the lifetime is crossed, luckily I crossed the lesion. This is actually again a wire. Microcatheter, with the help of microcatheter I did it. So I will just remove this microcatheter. They just give me trap fast.
But now you at least have a wire in the true vessel, and you have a better chance of working something like a Corsair or a Turnpike over the wire that goes in the true distal right. Now, does anybody here have laser?
Give me another 1.25 new.
No.
I would have done that because the boss
No laser.
not laser the wire. It's
Well,
not
you don't,
bleeding.
well, but it's easy to try.
I would have exchanged it with the taken a local wire by the side of it. Then
Microcatheter പുറത്തു വന്നു. Microcatheter എവിടെ? Okay, take it out. Inflate. എടുത്തോ. Just give me 1.25 fast.
Well, it's supposed to start at 9, but I'll let it take a few extra minutes and then it'll start. Because we have a few extra minutes for work discussion.
ലെഫ്റ്റ് കത്തി റിമൂവ് ചെയ്തിടെ
Give them more than like 3 minutes or something.
I actually taken the microcatheter back by a trap balloon again. So now I take only 1.25 again into the new wire. Probably if I cross, then that is finished. I think because of the two buddy wire technique, I have high chance of crossing the wire, balloon itself. Because now it is a buddy wire. Buddy is better than the anchor.
so what balloon have you taken?
Another 1.25.
No, which one is that?
1.25 Trasuna balloon. It's a thermo balloon. Where is the balloon?
വയർ എത്തിയതേ ഉള്ളൂ
Now it is coming down.
ഓക്കെ
Inflate. Probably it crossed.
Yeah, I think you have crossed.
20. Deflate. Yeah, I crossed. 15, 20. 22. Deflate. Now I crossed the lesion. There is a balloon coming down. I will be taking a 2.5 millimeter balloon fast.
Okay, we're going to give you 2
I'll
minutes.
take a 2.5 directly.
Yeah, we're going to give you 2 minutes, and then we will have
Okay,
to go
thank
to
you,
the
sir.
rest of the program.
Fast. This is a 2.5 balloon, which is Maverick, Quantum Maverick 15. I crossed 15. Deflate. Go. Deflate. Inflate. Deflate.
So could you give us one injection so we can take a quick look, and then we will leave you to go to the lecture.
മറ്റേ വയർ റിമൂവ്
Thank you, sir.
Excellent. So thank you very much. We'll try to come back to you toward the end of the session. But if not, we thank you for
Thank
your
you, sir.
efforts.
Thank
It's
you.
a nice result.
Thank you, sir. Thank you. Thank you.
So we're now going to go to the didactic portion of our program, and first we have a debate about left main disease. I would like to ask Dr. Yadavat to give us his perspective as a CT surgeon, left main disease. Let's leave it for the surgeons.
Mr. Chair, ladies and gentlemen, a very good morning. What we are trying today is to find an answer to this million-dollar question: how can we preserve the safety and effectiveness of an intervention that one can learn and perform routinely? It's not about doctor's name and fame, of individual bravado that I can do such and such, and it's not about soliciting patients. Before we actually go into the debate, let me recite and recapitulate certain incontrovertible facts about left main. It supplies a huge amount of myocardium. Any event is usually disastrous. Circumflex takes off at 90 degrees, something of import to a cardiologist, and atheroma usually continues from the distal left main into proximal LAD, into proximal circumflex, and at times there may be a ramus intermedius branch, as you can see here. There may be associated pathologies like left main ectasia associated with this. And most of them are eccentric and heavily calcific plaques. Hardly ever will you get a pure, exclusive left main bifurcation post-distal disease. And anatomy is important. Plain syntax score has been shown. Even the May Compare registry last month. Syntax score more than 33. There is a 40% higher mortality with PCI. But even with syntax score less than 33, look at the revascularization rates are much more with PCI, and revascularization, P gets revascularization. It's not just one revascularization. Look at that. If you get a revascularization, there is a 1/4 chance you may have up to 3 or more repeat revascularization. And there is a 3 to 5 times higher mortality with these repeat interventions. And that's why Gregory Stone himself said it's a real difference and should not be minimized. And it's not just the anatomy. You also have the associated comorbidities. And that's why all these additional scores like the syntax score 2 and the clinical syntax have been postulated. What about diabetes? All of these studies, syntax, freedom, cardia, the body 2D, it has shown that when you are a diabetic, the beneficial effect of cabbage extends to a syntax score of anything more than 23. What about chronic kidney disease, LV dysfunction, and they are there in the part of the latest guidelines. Common comorbidities, most patients presenting today with rheumatoid arthritis, hypothyroidism, they all are better off handled with CABG as compared to PCI. And then what about expertise? Look at the latest last year's data. Annual per operator 0.5 angioplasties in USA of left main per operator, and more than 1 per year, barely 15% of the cardiologists. And what is asked for by the guidelines? Minimum operator volume should be 25. So it's all right, ladies and gentlemen, if Professor Gambhir does that, but what about when bourgeois class like me do this procedure? And then bifurcation is different. The heart doesn't contract linearly like this. It's a squeezing motion, if you know the working of the heart. And when you have unusual torsion, flexion, stretching of those stents, you get catastrophic events because of stent fractures, because the left main bifurcation becomes stiff. And then there's an issue with bifurcation PCI in terms of angles. If it is a shallow angle, you have carenal shift. If you have a steeper angle, you have stent apposition problem and increased atherosclerosis. And even in that syntax study, restrictive bifurcation angle was an independent predictor of Maze. That's why way back Delta registry showed that the red line bifurcation always performs inferior to the green line, which is proximal left main. So what really, I'm not able to fathom why must you do a simple thing in a difficult way? Must you always commit harakiri? When you have such a simple and a straightforward procedure, and look at that, intervention-free survival of 20 years is 60%, and this is when we are talking of people in the 60s and 70s, almost approaching the normal life table. And this is for the bourgeois class surgeon, while for angioplasty, you need a maverick surgeon to perform the angioplasty. We have bypassed survival advantage, and these curves are diverging. Even in recent May Compare registry, there was almost 35% higher mortality with PCI. Noble trial, complete superiority of CABG, and even in the Excel trial, death curves diverge late. Now that is important that you follow patients adequately. It has been shown repeatedly. If you look at multiple versus single arterial grafts, if you compare at 3 to 5 years, there is no difference. When you look at 7 years, look at the p-value. It becomes statistically highly significant. Same thing with the Stitch trial. 5 years, no difference between CABG and medical treatment, but when you look at the 10-year extended study, CABG far superior to medical treatment. So we really need to follow up these patients. And that is exactly what happens because late events with PCI are there. 2% per year may events which occur beyond 1 year. And if you look at this recent last month's study, if you're looking at 1 year, the second and third generation drug-eluting stents perform better than bare metal stents. But if you look at 5 years, there is no difference. And that's why Gregory Stone said, while we have made tremendous advances in the first year after stent implantation, we have not made any advances between 1 and 5 years, unquote. Second generation tests, still ongoing risks with no plateau evident, again, unquote. So it's still an half-baked technology. We don't have a perfect stent. Even in the Excel trial, 30 days, PCI winner. 1 year, surgery starts showing better results, but look at 5 years, surgery far superior. But despite these results, what do we find? The results projected in the NEHM article, PCI and CABG are equivalent in syntax score less than 33. Multiple flaws with this trial, I'm not going to go. But most important, the primary endpoint was changed. You have biochemical definition. Now, surgery means cutting muscles. Enzymes will go up. Right from the word go start, you have, kind of had a trial which was designed against surgery, and then look at the conflict of interest with the industry-sponsored trial. This is an excellent trial. When they look at the Excel trial, if you use the universal definition of MI, 19% are getting infarct as compared to 3% in CABG. But if you use the SKY definition, this 19% becomes 5 and this 3% becomes 20. So that is what is important. If you take out the perioperative infarcts, surgery is a clear winner, and that's why they say that is the real MI, non-procedural MI. And look at the Fremantle et al. Study. He has no turf to protect. He's a statistician, neither a surgeon nor a cardiologist. 5 years, Excel per syntax, 23% increased death with PCI. That's why Patrick Meyer says NEJM should retract the article. And the controversy of all these things, the European Association has withdrawn from those recommendations. And then we have surgical advances. Off pump, look at the stick you use to beat the surgeons with CVA, 0%. And even if you look at the Excel trial, there was no difference in CVA. The neurological events were higher because the TI were higher. And look at the MECUS. If you do minimally invasive, our early results are matching the early results of PCI, and long-term results far superior to PCI. And then what you need to compare is with arterial grafts and not venous grafts, which have patency rate of almost 90% at 2 years. And I have no time to discuss all these issues, ladies and gentlemen. So to sum up, you must listen to the sane advice, and the sane advice of the editor of NAGM. Long-term outcomes with CABG are superior, and William Bodum sums it up. To quote, to camouflage some of these decisions by saying, well, the length of stay is longer, there is more bleeding, and more need for transfusion is really muddying waters. What is important? Survival and freedom for MI, and CABG is the best choice for most left main patients. Thank you.
Okay. Some pretty strong statements. So the opposing view by Dr. Gambhir is that angioplasty is equally effective.
Good morning, friends. I think this is the fourth occasion when I am an opponent of Dr. O.P. Yadav in this particular debate. And let's see. The two comments that I'll make at the outset is that when you debate a subject, there are two ways of doing it. One is you start criticizing your opponent or the technique that he uses. And the second is you make a positivity of your own technique. But I think what Dr. O.P. Yadav has said in the last 10 minutes, which was more philosophical, but targeted at the pitfalls and limitations of angioplasty, which is not true. Half of the data is untrue, incorrect, and is redundant. But let me start with the points that I have to say in support of angioplasty. Well, I must admit that, well, Andrea Gudzing in late 70s said that although angioplasty is very successful, but they have not been very successful in dilating the left main coronary artery, and that was very obvious because two of his patients died after left main coronary intervention. And therefore, he categorically stated in his paper that LMCA is a contraindication for balloon angioplasty. But then, over the next 10 years, there have been several strategies which have come forward to reduce the incidence of in-stent restenosis, which includes debulking devices, IVUS-guided stent implantation, and of course, to the turn of the millennium, the drug-eluting stents changed the entire scenario. Now, over the period of 2006 to 2009, there are several small registries and small studies which have compared PCI with CABG. And if you pull the data of the 6 studies, you will see here clearly that there is no significant difference in the death and MI between PCI using drug-eluting stents and CABG. But mind you, these are all very small studies and these are not randomized trials. So the year 2009 saw a tussle between the interventional cardiologists and the surgeons as to who would treat a patient with left main coronary artery disease. So to rest the problem and to look at it in the right perspective, 4 randomized trials have been done over a period of 10 years, and then there are 2 or 3 meta-analyses and a pooled data. Now, the first 4 out of the first 2 trials are with the first generation stent, and these 4 trials with the first generation stent have included 1,600 patients. The Syntex trial was the first trial to be published, which clearly showed that over a period of follow-up 5 years, there is no significant difference in MACE, mortality, and MI. However, there is a need for repeat intervention, but lower rates of stroke after PCI. Then came the pre-combat trial next year, which also showed that PCI is non-inferior to CABG with respect to hard endpoints, like MACE, death, MI, and stroke, but you need more often repeat intervention. In the next couple of years, 2 more randomized trials came and got published, but these were with the newer generation stents. Now with the Excel trial, they did not take into consideration, they took only patients with low intermediate score. They did not include patients with high Syntex score. And the stent used was a newer generation everolimus eluting stent. Now, Noble trial used a first generation stent in 18% and a biolimus stent in 89%. Now, another difference was that the endpoints used in the Noble trial were very soft endpoints. They also included repeat revascularization, which is not a very hard endpoint when you look at the data of left main coronary intervention. Whereas Excel included only patients with left main all-cause death, MI, and stroke. Now, in Excel trial, there was no significant difference in the primary outcome at 5 years with regard to death, stroke, MI, and myocardial revascularization. But at the, when you include revascularization, certainly the CABG was superior as compared to the PCI. And this was primarily because there was a higher need for repeat revascularization with PCI. When you look at the Noble trial, again, it is the only trial which showed that CABG is significantly better than PCI, but there are a lot of limitations and pitfalls in the Noble trial, which OP has not touched at all. The all-cause mortality, there was no significant difference even in the Noble trial, but it was only the repeat intervention which was higher after PCI as compared to CABG. So what have we learned from these 4 mega trials? The 3 out of these 4 trials concluded that there is no significant difference between PCI and CABG with respect to irreversible endpoints like death, myocardial infarction, and stroke. However, only exception being the Noble trial. Then we had a meta-analysis of 4 trials, 4 randomized trials, which included a total of 4,400 patients, and follow-up was 5 years in all of these patients. And you look at the Kaplan-Meier survival curve, there is no significant difference between 2 modalities of treatment when you compare PCI using drug-eluting stent versus CABG. And again, comparable risk of composite endpoint of death, MI, and stroke. There is no significant difference in all-cause mortality, no significant difference in cardiac death. However, again, repeat intervention was required more often after PCI compared to bypass graft surgery. Now, when you look at a glance these 4 randomized trials, look carefully that in terms of mortality, there is no significant difference whether you take PCI or CABG, and that is the most important endpoint. Repeat intervention, however, is required more often in almost all the studies as compared to CABG. Myocardial infarction rate is higher in the Noble trial because of the problems in the definition of the myocardial infarction. In other studies, even the rates of myocardial infarction were similar with the 2 modalities of treatment. Then we had a pooled analysis which looked only at the mortality, and this was a study which included 11 randomized trials, including total about 11,000 patients with a mean follow-up of about 4 years. And the only endpoint was all-cause mortality at 5 years. And when you look at the mortality, there is a similar mortality after 5 years, regardless of the diabetic status. Dr. Opiada, please mind it. All patients with diabetes and without diabetes, there is no significant difference in mortality. Similarly, regardless of the syntax score, there is no significant difference between PCI and CABG. So they concluded that there is no benefit of CABG over PCI with stenting in left main disease with respect to 5 years all-cause mortality, regardless of the 2 major important diseases like diabetes mellitus and a high syntax score. Now we have 3 limitations of these trials. We use BMS or first generation stents in major trials, the first 2 trials. Then less than 10% of the studies use imaging modalities to assess the immediate outcome of PCI, and the maximum follow was limited to 5 years. But when you look at the relationship or the difference between first generation stent versus second generation stent, there is a study which clearly showed that the everolimus eluting stents are superior to the first generation PES stent with regard to MACE, TVR, and ISR. Also, there is a meta-analysis of using the LMCA angioplasty using intravascular ultrasound guiding versus angiographic guided. And this clearly showed that MACE, all-cause mortality, cardiac deaths, MI, stent thrombosis, and target revascularization were all lower in a IVUS-guided left main intervention as compared to angiographic-guided stent implantation. So the meta-analysis clearly stated that IVUS-guided stent implantation of DES for LMCA disease has a much better clinical outcome, and particularly in terms of reduction in death, MI, and stent thrombosis. Now, we have always been criticized that we don't have a long-term follow-up.
Now look at 10 years follow-up in the Syntaxis trial, which has now come up in the Lancet. They enrolled 1,800 patients, 10 years follow-up, and the only endpoint was all-cause mortality at 10 years. And this trial included, mind you, Dr. Yadav, patients with left main and multivessel disease were almost 2/3 of all the patients. It was only 1/3 of the patients who had an isolated or small disease. There was no significant difference in all-cause mortality at 10 years. And so this trial clearly stated that there is no difference in mortality at 10 years between PCI and CABG in patients with left main disease. So look at the guidelines. 2005, when LMCA treatment was only class C indication, in 2011 it has risen up to class 2A in most of the guidelines. This is my own data, which I will not go into the details, but I'll tell you that this is the case which even the surgeons had refused. So it is only the angioplasters who could do this case, and with excellent result, and patient has been followed up for 5 years. Now, so from interventional perspective, I would say PCI should be preferred in LMCA acute occlusion, abrupt occlusion, LMCA osteal shaft stenosis, selected cases of LMCA with bifurcation stenosis. I do admit that certain cases should go to surgeon, like LMCA with 3-vessel disease with diabetes, possibly severe LV dysfunction, and MR. So, certainly the scales have tilted in favor of DES, PCI using DES. So it's for you to judge. CABG I would call it the old technology, PCI being a new technology. So take-home message is LMCA stenosis is no longer the domain of surgeons. PCI using drug-eluting stent is equally effective and viable alternative to bypass graft surgery in selected group of patients. With that, thank you very much.
Okay, so we have 5 minutes of discussion time as well as the potential for rebuttal from each of the speakers. So before we go to rebuttal, do any of the panelists have any questions?
No, I just have a comment, as both of the speakers have told very clearly. So there are cases better suited for PCI, there are cases maybe better suited for CABG. So instead of saying all cases of left main, we should try to differentiate which cases for which. That is my comment, and I think the other comments are welcome.
So let's have a couple minutes of rebuttal.
Well, let me start with where Professor Gambhir sir finished. You said there are certain cases where we may allow the surgeons. Let us understand those cases. Patients with multivessel disease. 85% to 90% have distal multivessel disease. So you grant 85 to 90%, you give it to us. Number 2, you said diabetes. Almost 40 to 50% have diabetes. So out of that left 10 to 15%, you give that 50% to us. You have left LV dysfunction. You give that to us. I think you almost give 95% to us. We are not greedy. Sir, have those 5%. Thank you for those small mercies. As far as the comparison, the entire first half was left main, but the debate was bifurcation. It was not left main. It was just bifurcation disease. So we need to have data. How would you defend 0.5 angioplasty per year, 3 million angioplasty data from 2019 of USA published, and it is probably much worse in India. And the real change will come if you're aware of the Syntax 3 trial or the Syntax revolution, when the radiologist will become the gatekeeper. The cine angiography goes, and then he does the angio and decides which is good for the patient. And when the cardiologists are not the gatekeeper, then we will have the real test of the time. Thank you.
Doctor,
Professor Gambhir, your turn.
Can I speak from here?
Sure, of course.
Well, thanks, OP, for pointing out a few issues. I don't think you have taken and listened to my talk very carefully. Well, when I said in the end, the pooled analysis, regardless of diabetic status, the end point was mortality. You see, what scares me today is mortality.
I'm not scared about repeat revascularization. I do admit that repeat intervention is required more often after PCI, but the mortality and the risk of repeat intervention is same whether you undergo first, second, third, fourth, or fifth. We have done 5 interventions and the risk is the same. So please take this point very carefully, number one. So mortality is certainly as bad or as good as with CABG. In diabetics and also in patients with high syntax score. So please, although 1/3 of the patients are diabetic, but they do as well even with PCI. Second is multivessel disease. I did say that even in the syntax trial, 2/3 of the patients had 2 and 3 vessel disease, they are multivessel disease. And in the pooled analysis, which I showed with a 5 years follow-up, there also 2/3, 67% of the patients had 2 and 3 vessel disease, number one. Number two, almost about 70% of these patients had bifurcation disease, and they were all treated by PCI. So I'm not excluding a bifurcation, and I'm not saying that I'm talking only of the simple isolated left main coronary artery disease without bifurcation. All these patients, because I know that 2/3 of the patients with LMCA disease have got a bifurcation stenosis. So I think I have covered all those areas, but look at the hard endpoint, mortality. Mortality is certainly in 10 years follow-up in the syntax trial, in the syntaxis trial now has shown there is no difference in the mortality. So I think we should. I'm still giving to my friend OP a few cases which I do agree that mitral regurgitation with multivessel disease certainly should go to him because I still can't treat mitral regurgitation. And some few cases where we have got multivessel severe disease downstream and let him go to the surgeon. With that, I think I have made my point.
Thank you.
I'd like to ask Gary a specific question from Dr.
So
Dr.
give
Gary
him a
Min.
chance, then you.
Yeah.
No, go ahead.
Question to Dr. Yadav. I am Dr. Hitesh Shah from Ahmedabad. As you rightly pointed regarding the operator volume in bifurcation left main disease, but if you compare, you didn't show the operator volume in CABG because the trials, Syntax and Excel, they have done the highly competent surgeons where they do the bilateral internal memory grafts. In our setup, the surgical standards, and that has never been compared. We have the 3rd generation DES, 2nd generation DES, and Dr. Gambhir has rightly pointed out, but the operator efficiency and operator volume have never been incited as far as the CABG is concerned.
I didn't get your question at all. I mean, you're saying operator volume has not been...
You have pointed about the 0.5 in the PCI arm, but as far as the centers of the CABG where this data is pulled, it is the highest efficient CABG centers where the competent surgeons are there. And if we compare here, if you are pointing in Indian setup, it's too inferior.
See, Lima to LAD is virtually used in 95% and above across the board throughout the world today. The problem is with the second arterial conduit, I do agree. But Lima to LAD across the world, and that is one which gives you the survival advantage.
OP, let me just once more. OP, all these trials had used Lima in 95% of the cases, and these results of the equivalence between the two modalities are with Lima being deployed in 95% of cases. So don't re-emphasize this point again.
Okay.
Dr. Modi?
Dr. Modi, last
I just wanted to ask you, I believe most of these randomized trials exclude 20 to 30% cases from the registry which cannot undergo angioplasty. They are already sent to the surgeons before they are randomized. Is that true?
Well, certainly, these are the trials where there is a hard team which looks at the case carefully, and there are certain patients which have been kept off either as bypass surgery and also from the angioplasty. So both ways they have been excluded.
No, I mean, when you exclude the patient, most of the patients undergo surgery and not angioplasty, obviously.
Not
because,
so.
Yeah,
No.
So again saying that all patients of bifurcation left main are equal for CABG and PCI will not be true. Those patients who can undergo either of the procedure, there is no difference. But some of the patients who are excluded, you cannot say that they are same.
But some of the patients who cannot be taken, they cannot be taken for bypass graft surgery also, and I have shown you a case, and I can show you at least 15 such cases.
that surgeons also runs away and we take them up.
For the Excel trial, let me quote the exact statistics. 58% people were refused for angioplasty. Please check on these facts.
Who refused? Patient refused?
No,
or
no.
Heart team
Okay,
refused.
okay, okay.
They were said we can't give you equivalent.
Heart team refused.
So they went and underwent CABG, the point that you are making. Thank you, sir. Yeah.
I'm turning their microphones off. Do we want to go to the cath lab now or later? Let's go back to the cath lab if we can. No, I'm not going to. Perfect. All right. So we're now going to go to the last part of the program, something about imaging and hopefully this is going to work. Yeah. Okay, so the problem is I don't have a good pointer. That's not going to make it easy. But I will try. So we're going to do, in about 10 minutes, go through a quick atlas of intravascular ultrasound. This is a normal artery on the left. These are atherosclerotic arteries. You can see intima media adventitia. You see plaque accumulation. We classify plaque by IVUS as hypoechoic, which just means it's less dense compared to the adventitia. Hyperechoic non-calcific, which means it's more dense or as dense as the adventitia, but you don't have shadowing. Or calcific, where ultrasound does not penetrate the calcium and you see shadowing as shown here, or even better reverberations because the ultrasound bounces back and forth between the transducer and the calcium, causing ghost reflections here. Here are examples of reverberations with calcium, 1, 2, 3, 4, and they actually continue out almost indefinitely. You also see the same thing with metal, and you especially see these reverberations after rotational atherectomy because the surface of the calcium is polished. In terms of calcification, shadowing is more sensitive, reverberations are more specific in terms of the detection. Thrombus is not a strength of intravascular ultrasound, although these are two clear examples where you see a thrombus floating in the lumen here and also around here. But I clearly concede that thrombus is not or IVUS is not the best technique for detecting thrombus. However, we do have something called attenuated plaque. Attenuated plaque is plaque that's not reflective, but you do not see the adventitia. It's not reflective, but you do not see the adventitia. And this represents a fibroatheroma with a large amount of necrotic core and lipid. And if you place a stent, such as you see here, you have a lot of tissue intrusion into the stent and a high rate of distal embolization and no reflow because this material embolizes downstream. This is actually a very important observation in terms of an unstable lesion in undergoing stent implantation. The quantification is very straightforward. We, quite frankly, developed this 25 years ago. You identify the proximal reference, you identify the distal reference, you measure lumen and adventitia, and then you identify the center of the lesion, you measure lumen and adventitia, and you get a whole host of calculated numbers, such as plaque burden, which represents the percentage of artery occupied by plaque, area stenosis, similar to angiographic diameter stenosis, eccentricity, the ratio of maximum to minimum plaque thickness, and remodeling, the ratio of vessel area or EM area at the lesion compared to the proximal and distal reference. Why do I mention remodeling? Well, the pathologist Seymour Glagoff years ago described the phenomenon of positive remodeling, that is, the vessel grows to accommodate plaque deposition until there's a certain plaque burden where the vessel can no longer grow anymore, and that crossover from just remodeling to stenosis varies from patient to patient. We can see now with intravascular ultrasound confirming the Glygovian hypothesis. Here you see two right coronary arteries. Yes, there may be a focal stenosis, but there's a huge plaque burden proximal and distal to the stenosis, representing positive remodeling with plaque accumulation. You can also have overshoot, also described by Glygoff, early in the disease process where the growth of the artery, the positive remodeling is greater than plaque deposition, and that's responsible for ectasia, as shown here in these two examples. The vessel is actually larger, but there's no lumen compromise. We can classify lesions as having positive remodeling, that is, the vessel area at the lesion is larger than and the proximal and distal reference, or intermediate and negative remodeling, where the vessel is actually smaller and shrunken, and often with no plaque accumulation, as you see in the bottom example. Greater positive remodeling indicates more lesion instability. Negative remodeling is typically seen either at the ostium or in a chronic stable lesion. But we can also look at plaque rupture by intravascular ultrasound. You see in the top example, plaque rupture without thrombus formation here, the big cavity with the lateral rupture site, and in the middle example, thrombus within the rupture cavity extending out into the lumen. Calcified nodules are a particular subset of calcified plaques. They represent a cluster of calcium, of small calcific deposits within a necrotic core that erupt the fibrous cap and accumulate in the lumen with this irregular appearance. And these are really problematic for doing stent implantation. The calcium spicules can puncture the balloon and cause a lot of rupture. Balloon rupture, they can catch the stents, and they're associated with a lot of periprocedural MI, as well as a high rate of restenosis after calcium, or after stent implantation. And often they do better when treated with some kind of plaque modification device first. Spontaneous coronary artery dissection is the fourth most common cause of acute coronary syndrome, the first being plaque rupture, the second being erosion, the third being calcified nodules, as I just showed you. But spontaneous coronary dissection is a separation of the vessel wall in a non-atherosclerotic segment, very similar to an aortic dissection. And you see a collapse of the interelastic lamina, expansion of the extraelastic lamina with a hematoma between the two. These are non-atherosclerotic, and if identified and the patient can be stabilized medically, they should not be treated with stent implantation because the patients do better medically than they do with stenting. We can also detect muscle bridges. So here you see a muscle bridge. If you go from the third from the left, you see this echolucent area surrounding the vessel wall. Why are muscle bridges important? Because they're poorly identified angiographically, and if you implant a stent into a muscle bridge, usually distal to a stenosis, this is associated with a higher rate of restenosis as well as chronic strut fracture. Our aneurysms can be assessed by intravascular ultrasound, looking at the aneurysmal segment compared to the proximal distal reference. In the top example, you see a true aneurysm with a tight stenosis proximal and distal. Often these tight stenoses are calcific, and you see the aneurysm here with a very, 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 very large vessel area. And in the bottom example, this is a boy with Kawasaki's disease, calcification followed by a large distal aneurysm. When you're doing intravascular imaging, particularly at the ostium of either right coronary artery or the left main, you must disengage the guiding catheter to see the true ostium. I've seen examples where the physician misinterpreted the guiding catheter as a focal stenosis at the ostium. So you must disengage, and see a transition from the vessel wall to the aorta. Here you see an osteo-right coronary artery, which typically has a lot of calcium. And here you see a focal disease at the ostium of the left main with some amount of lumen compromise. Stent under expansion is the #1 cause of restenosis and stent thrombosis. Here you see an example of a calcific lesion in the proximal LAD treated with stent implantation and a reasonable angiographic result, but by IVUS imaging you see a stent that's barely larger than the IVUS catheter because of circumferential calcium. Malapposition, which people worry about a lot, is actually much less important. The only concern is getting a guide wire behind the stent struts, but malapposition does not cause stent thrombosis. Malapposition does not cause restenosis. The number one problem is underexpansion. Malapposition is not that important. Edge dissections, however, are very important. Here you see examples of edge dissections in 3 examples: mild, moderate, and severe. The moderate and severe ones should be treated, as well as intramural hematomas at the edge of the stent, which is a dissection down to the media with accumulation of blood, and these are associated with a high acute event rate because of collapse of the distal lumen. We can even also see perforations, and you can see a perforation here. I have a problem with my pointer, but a perforation of the vessel wall with accumulating contrast or saline outside the vessel wall. We can also see stents that have become dislodged in the left main. Here the stent is floating left main because it came off a balloon. We can look at CTOs and use IVUS to guide CTO interventions. So my time is up. And I just want to thank the organizers for inviting me. If we had more time, we could look at more images because there's no substitute for looking at images in order to understand them. Thank you very much.
Thank you, Gary. I think we can now look and listen to more colorful technology of OCT from Dr. Guillermo from Italy.
Yeah, Dr. Guillermo was not able to come due to traveling issues, so I will try to replace him with some images. And lucky enough, the title I have to do the OCT picture is perfect. And just you have seen all the nice slides from Gary Mint helping us to understand IVUS, but he had some troubles with his pointer. And easy thing about the OCTs, I won't need the pointer, you will just see it. So this is your talk.
Yeah, if you have just words, it's easy.
You have to make it easy. The OCT you can use in several moments for the diagnosis, the optimization, the sizing, stent expansion, evaluate the acute results and the outcome. The advantages are there, so it's fast, it's high resolution, it has good tissue differentiations, and potentially it reduces the need for angiography because you have seen your stent results so much immediately. I just want to take a few examples. We cannot show all the clinical diagnosis. Gary has given a great overview of all of that. And I wanted to make the introductions with the patients as well. It helps you a bit better to understand. A 50-year-old male patient, no risk factors, chest pain, originally 24 hours, increasing for the last 2 hours, ECG showing a STEMI initially, and then your aspirin, ticagrelor, and heparin, and his urgent angiography. Now, this proximal LED doesn't look total normal. I was zooming in a bit for you. You're in this area, and if you zoom in, you will see that there is pretty some haziness, questioning what we have to see. So originally I looked at it, and we can see here, this is classical thrombus with a high blockage of penetration. You see the irregular scape on it. You see it has a length of 8 millimeters, etc. So in this case, we decided not to treat this immediately with stenting, but as we expected, this is a thrombus, and we cannot see a plaque rupture in this location. I couldn't see a plaque rupture in any locations, but maybe underneath you don't know what exactly is going on. And we started to treat the patients with some 2B3A for several times, and then have a relook at 1 week. Vessel angiography-wise looks much better. And after just this period, you can see how much it has been cleaned out. And this is classical what was just mentioned about a plaque erosion with thrombus on top of it, treated with medical therapy without a stent. You can see some erosion aspects, but very clear. No, this is just an overview of where the things you're going to look at after stenting, either small dissection areas, larger dissection areas. Are they going deep into the tissue, or just the interluminal hematoma? Just talked about the stent failure, stent thrombosis, late stent failure, and this is a great overview of the work done. In the PESTO study, there was the Prestige as well. You can see the different kind of patient images where we have either plaque ruptures, you have malposition, you have uncovered struts, and especially underexpansion as one of the main causes of late stent failure, and malposition and image B. I will show you a clinical example from my experience. A 71-year-old guy, a non-STEMI, had a stent, the BMS, many years ago, over 20 years ago, and you can see already on the angiography there is an in-stent restenosis. We studied that with the OCT. You will find out there is significant lesion, and if we do the cross-sectional images, you can really identify within this plaque the amount of circumferential calcium within the stent. And you know that this is going to be a very difficult to treat lesion. Have to think about what kind of technologies you want to use, either just balloon dilatation, or that you have to have high pressure, rotablation, etc. No, the operator decided to do a balloon dilatation, was rapidly looking at the image, said that's okay, put in the stent, and realized he had a problem after stenting because there's still under expansion inside the calcium. Maybe TIMS-free flow, so not an acute serious problem, and tried to dilate, failed to do much more dilatation, and decided to wait and see what was happening to the patient in the future follow-up. Now, the post-stenting, you can understand with the OCT how it looked like. You see the deep calcium, you see the underexpanded new stent, and in the longitudinal reconstruction, you can really recognize the proximal 7 millimeters as being underexpanded. No, the patient was having chest pain. We wanted to demonstrate ischemia before we go to do a highly complex procedure with potentially rotablation of an implanted stent. So that was confirmed. We went in, tried first the simplest solution with a high pressure balloon, initially at 20 atmosphere, just as the previous time, failed to expand the stent. Lucky enough, that one we could inflate to 30 atmosphere. We had good success of opening the artery, just with some additional balloon dilatation. We did now, again, the OCT to see what we are, if we can go forward. Yeah, seems to be stuck.
So could we have the slide advanced, please? It appears to be stuck. Yeah.
Yeah. Look at my
Oh,
mouth.
that's
That's
good.
nice. You see that you have this young kids doing this
Yeah,
with your
so
photos,
we
you
have
get your
there's some
picture.
technical problems. Can we
Do
have
Snapchat or something
There
like
we go.
that. I was just waiting. It will come up, I think. Trust on the team for the audiovisual controls. Yeah, I said it's fast.
I'm
See,
trying
if
to
you
figure out
really-
how I can blame this on OCT, and I'm having a hard time.
So listening at your presentation, Gary, you know, I have tried to show all the advantages of OCT. I didn't.
Pose some issues. Like Gary said that malapposition is not a predictor of late restenosis or any adverse acute event. Whereas we in OCT now understand, and there are studies which have shown that malapposition is one of the predictors
of stent thrombosis.
No, absolutely not. I totally disagree. So
You
there's
disagree
very...
with the study or you disagree with the...
No,
with
I have the data.
There's no data.
Yes, there is data.
There is data.
There is data.
Yeah.
So if you look at Francesco Prati's work, from Rome, Italy, he has several studies, and in 3 of those studies, including very, very careful, detailed analysis and quantification of acute malposition, there is no relationship between the presence or severity of acute malposition and events at 1-year follow-up. None. There is the data.
So
now, the difference is that at follow-up, one of the causes of late stent thrombosis is late malposition. But that typically develops during the post-stent follow-up period because of interaction of the stent and the vessel wall. If you will, it's a toxic effect of the stent on the vessel wall. And
So-
those are the ones that develop late malposition.
So
But
you're
acute-
trying to differentiate under expansion and malapposition.
So under expansion is a small stent,
Under expansion, we're talking
whether by
malposition.
IVUS or OTT. Malposition is a stent that's decent in size, but is not in contact with the
Not in
vessel wall.
contact with the vessel wall.
You got your slides.
Yeah, thank you. I think it's good to have that discussion. So these are the high pressure dilatations, 30 atmospheres, and now we can see the longitudinal reconstruction after the dilatation, and it really looks much more open. We had some edge dissection because the balloon was also outside, and we later on put on the second stent. So this is a comparison of the longitudinal reconstructions with the stent indicator on the OCT system. You can see the under expansion and the fully open stent afterwards. This is, again, the cross-sectional images at the same locations, pre and post. And I hope it doesn't get stuck again. After an additional stent to cover the stent dissection. Just want to show another case of patients to optimize the stent implantations, left main bifurcation, 70 years old, inferior infarction, and having a serious problem in his left main disease. Large left main over 5 millimeters. So think about the strategy, discuss this with the surgeon, and then due to the low syntax score, we decided that we could do PCI for that patient. Here you can see the lesion, mainly going into the LAD, but osteal disease of the circumflex, but potentially suitable for provisional crossover stenting, treated with some predilatation, implantation of a stent, opening up to the side branch, and then do end control angiography. Now, we will show you the OCT of the wires which has been in there, and you can see that this was a pretty small balloon initially, and this side branch is not open yet. And there are some more points to show. You see the 2 wires, both are in the proximal cells. That's not your optimal location to have full opening of the side branch. You can see under expansion in the proximal LAD at 20 millimeters just before the bifurcation, and not fully open that. So we did re-engage, new wire, distal position, low pressure, high pressure, a little bit larger balloon, and I will show you, again, the angiography already looks better. And now we can see the OCT, and you can see how much the circumflex, I marked it there with the CX. You can see the wire in a distal position, and how much it has now opened and stabilized the ostium of the circumflex in this reconstruction. You can see it on the 3D reconstruction, which is suitable for your software. The ostium of the circumflex is now much wider open. I have another 2 minutes now. So that's, I think, my last example where I use OCT. In this presentation, 3D reconstructions about an occluded side branch, a 54-year-old male patient. You can see poor ejection fraction, previous infarctions, and some significant disease. You can see several diagonal branches, anterolateral branch D1, D2, and then the occluded CTO of the LAD. I had to work on it a bit, but we crossed it with the wire, put a safety wire in the diagonal, and then started dilatation and implantation, resulting in an occlusion of the diagonal, second diagonal vessel branch. You can see it on the OCT, put an arrow marker to see how the jailed safety wire is coming off through between the struts through an occluded segment of the side branch into the main branch. So What you do, you can see a wire in the side branch without an ostium visible on the OCT. Failed to rewire that, integrate that. I was not happy about that. In the end, the only solution is there. You can see one wire going in a dissection in the side branch. That was not a good direction to go. So I have to change over my strategy and then make it pretty aggressive and do a balloon on your safety wire. That, of course, is not a very easy thing to do. Usually it doesn't give, hardly will go in between the stent and the wall. I had to use some anchoring technique to get it in, realizing I was potentially going to disturb the main vessel stent. This one should go. I hope so. No, the movie is not there, but you can see the distortion with the yellow markers. I still have my main branch wire in there, so I can easily restore the apposition in the proximal segment of the stent. And you can see how it has been distorted by the red marked struts of the stent because they are above 300 microns distance to the wall. In the end, we had opened up the side branch. I did bring in a new wire cross-distally and find a cell which was open to the thing, to the vessel, and had a new cross into the side branch. This is to pull back with the OCT2, the central recross. Maybe I skip that for the time being. This is more the central recross, which was more happy. You can see both wires are inside the center of the stent. So I was happy to inflate, do the kissing, do the reconstruction, and see that we will get better apposition now and have the vessel to the side branch open. So in conclusion, I think we're going to summarize the OCT. It has easy to understand images. It is pretty fast. It has high resolution. It can help you to differentiate in the tissues. And we think about the contrast. Is it more contrast? Is it less contrast? But you have, with a 10 cc injection, usually a very good impression, and you don't have to do multiple angiographies to have an idea of, to avoid distal edge dissections or control your distal position. Thank you for your attention.
So I'd like to make two remarks because our time is up. The first, I want to thank Robert for stepping in because Giulio Guaiumi, who was supposed to give this talk, was recalled to Italy because of the coronavirus.
Yeah.
And so he could not be here. The second is whenever we have these IVUS OCT discussions, I don't particularly like them because I think for about 85% of your cases, you can use one or the other. And the argument should be imaging versus no imaging rather than IVUS versus OCT. There are clear situations where IVUS is better. There are clear situations where OCT is better. We did not get into it, but for the vast majority of cases, which is stent optimization, you should just use one or the other to get the best possible result.
Fully agree, John, and no time to discuss it when OCT is not a good option, and there are clearly situations where the IVUS is still very useful to do it even over the OCT.
I think with that we conclude this session, and we would like to thank all our foreign speakers and including my own friends and colleagues from here and all the participants. Thank you very much. Thank you, Gary, and thank you.
Thank you, speakers and chairperson. Now we'll quickly move ahead to our next session, which is cath lab challenges. And I would like to invite chairpersons for this session, Dr. Borner, Dr. Ajit Kumar, Dr. K.U. Parekh, Dr. Aditya Kapoor, Dr. K.K. Agrawal, Dr. James Nolan, Dr. H.K. Chopra, Dr. Kinzo Ueda, Dr. Vijay Trahani. And I would also request our moderators to take their respective seats. Thank you.
No problem.
止めてでライブ出して。最初の出てるやつがちょっと手前なの。ちょっと手前から分岐してんの。Hello, can you hear me?
Yes.
Okay. So I guess Dr. Berner is sitting there.
Yes, I'm here too, Osama.
Okay.
We have a panel, and Sam Matthews is also
Hello.
here. So please introduce your case.
Okay. Okay, thank you. So, Dr. Habara will present patient profile right now.
Okay.
So let's switch to the Dr. Habara.
Yeah. Can you hear me? Can you hear me?
Yeah, we can hear.
Okay. Yeah. Okay. So this case is a 70 years male, and diagnosis is a stable angina. So today's target region is a proximal LVD CTO, and so coronary risk factor is hypertension and hyperlipidemia and past smoking. So this case was already treated RCA and circumflex at the end of the last year and so this year. And so JCT score is a 2 and the syntax score is a 15.5. So EGFR is around 60 and LVEF is about 70%, so that cardiac function is so good. And so the case is that there is some collateral. So this is, can you see the angiogram? So there is a septal to septal, so this is from RV branch to the LAD distal. And so this is major collateral from the conus branch to the distal LAD. And so CTO distal target is LAD and so diagonal bifurcation. And this is cardiac CT. So cardiac CT shows CTO length is around 12 millimeter. And the major problem of this case is blunt type of the CTO entry. And so at the entry, so there is some calcification. And this is also cardiac CT, and that's all. So please state Dr. Kato.
Okay. So we prepared a relatively simple LED CTO. So from the CT angiogram, we guess the occluded vessel is relatively straight. But difficult to see the CTO entry. But collateral from separated conus branch is revealed the CTO exit. It's very clear. So to enter the CTO, we will try the IBUS guided wiring. And also to cross this CTO, we will show the IBUS guided wiring. first, we will try to enter the CTO entry. So I will show the IBUS image. We will pull back from the septal branch. So this patient has a very unusual anatomy of LAD. So just like double LAD, the patient has a very big septal branch. Also the main branch of LAD is completely occluded. So I pull back the IBUS from the septal branch. Okay, I will show. Can you see the IBUS?
No, not yet.
Not yet. Okay,
We,
stop.
now we see the IBUS.
Oh, okay, okay. So you can see the occluded LAD at the 10 o'clock here. But from the diagnostic angiogram, we expected the CTO entry is a little bit more proximal. That's not true. The IBUS revealed the true CTO entry was a little bit distal to the first band of the LAD.
So there seems to be some calcium in the wall, of the proximal cap.
Yes. But we are lucky. The true entry of the occlusion is no calcium. So we can see the calcium just behind the true entry. So probably the wire can get in the CTO. I hope.
Okay. For visualization, you have a Caravelle in the conus branch. Am I to reduce contrast?
Yeah. Yes. And also the stabilize the catheter to the ostium of the separated conus branch is very difficult. So the catheter is very unstable. So I put the wire into the main branch of the RCA, and then I put the guide wire into the separated conus branch. Then I put the Caravelle to the conus branch. The contralateral injection was done through this Caravelle catheter. So can you see the angiogram?
Yes, we see the angio.
We we made a marking, so you can see the two markers. Can you see the three markers? So the mirror of this IBUS is the proximal two between the proximal two markers. Then the true entry of the LAD is around there. So I will try to puncture the CTO entry. Of course, we can see clearly the entry from the angio. So we need the IBUS guide to get in the CTO. So to IBUS guided wiring, we prepared a special system. I use the one guide wire and IBUS catheter on that guide wire. Also the Sasuke is on the same wire. So this is
So you have one wire in the side branch, you have the distal IBUS, and then in addition you can bring the Sasuke on the same wire.
Yes, that's right.
Okay, that is something unusual.
We call it strip stream technique. Anyway, so now the tip of the cassette, the Sasuke is linked to the LED. So I will move the IBUS to show the entry. So we should leave it there.
So to make it clear, it's very unusual. You have a very short monorail part on the IBUS, of course. Yeah.
Yes.
and then you can bring the
This is the
Sasuke.
thermo IBIS. Yeah.
Okay.
Uh,
So that may not work with every IBIS system.
Gaia next to it. Next two. Yeah, for this technique, we need the thermo IBIS, the double R system. So this system, this IBIS catheter has a very short molar tip. So we can use this catheter for this technique.
This working projection is okay in the right anterior oblique? You think this working projection is okay in this right anterior oblique? Or you could go to the LAO where you might still see some, at least the side branch angulation could be seen, because here we are seeing them parallel.
Yeah, this patient has a transverse position of his heart. So we need a very deep caudal view to see the ostium, or to see the proximal part of the LAD. So the deep LAO view is impossible. So we can't see clearly the ostium of the CTO. But now we have IBIS. So IBIS is very useful in this situation.
What is the wire that you want to use for the first puncture attempt?
Yeah, the Gaia next 2. So,
Gaia next to
GN2.
Yes, Gaia next 2.
Will you put an additional bend on the tip, or you take the pre-shaped?
Yes, yeah. We need a second curve, a relatively big second curve.
So we know the Gaia is pre-shaped, but he has added a bend to increase the curve to have a chance to get to the cap. And now we see the IBIS at 9 o'clock, 10 o'clock. The wire, that would be the ideal position.
So Dr. Nass will operate the IBIS catheter. So he threw back the IBIS a little bit.
Dr. Kato, we can't hear you.
Yes, we can.
Your microphone is a little bit low. Maybe they can increase the sound.
Your volume.
The volume.
Okay, I will.
マイクロフォンのボリューム上げて加藤先生の。
They can throw back. No, not proximal. Okay. もうちょっとじゃあ実際ですね。方向が違うね。
So we see the wire that is on the IBIS at 11, and now at 10 o'clock or 10:30, we see the Gaia.
To the distal. もうちょっと実際で。Now the wire is getting the CTO entry. Can you see the IBIS?
Yeah, we can see that.
Yes.
We can.
Can you see the IBIS?
Yeah, we can see the guy next around 11
So
o'clock.
the IBIS showed.
Yes, you seem to go.
Yeah. The guide wire is already getting.
Yeah, looks to be.
At 9 o'clock.
Okay.
Can we see the angio as well, the fluoro?
Okay. で、さっきの言ってた例に戻して。
It will be nice if you can show fluoro and IBIS parallel.
Working view 戻して。
Kato, can you ask the technician to show us the IBIS and the fluoro together?
Sorry, I can't hear you.
We are seeing the IBIS. We are seeing the IBIS. We also want to see the fluoro.
the fluoro also.
Okay, okay. Now, can you see the fluoro now?
Not really.
No.
Now we changed the projection. It's now with the areocaudal and areocranial.
Show us that.
Dr. Kato is operating it from the areocranial now. Can you see the angular image?
We can't see the fluoro. We are seeing your fingers on the table.
Okay.
Remove the camera and show us the fluoro.
So, yeah. Now you can see the fluoro.
We can't.
Can you see?
We can't see it.
You can't see. フロールが向こう見えてないよ。
Yes, now we can.
Yeah.
Yes, okay, okay. So, I will do the tip injection. This view, okay. Okay. So in the beginning, I explained this CTO vessel is relatively straight. That's not true. I expected the long CTO entry. So this LED is a little bit the bend at the bifurcation. So we have to turn to the distal here, and also we need RA view. So this view is just from the tangential direction to the myocardium. So this view is very useful to recognize the
Progress
gap
of the wire.
between the wire tip and the distal true lumen. So, okay.
In the meantime, I can answer a question from the audience that was regarding the IVUS. This is a mechanical probe, the Terumo probe, as compared to a Volcano. And the Volcano has a longer monorail part, so you couldn't use it in this situation. You need a very short monorail. I think even the Boston has a short monorail to get this double lumen catheter right close to the tip. Now the problem is you have a bend on the Gaia, so the Gaia is not as controllable as you would like, certainly.
Yeah, this is the Gaia next, so more controllable than the Gaia.
But you have two bends.
Yeah. Actually, after getting into the
Yeah.
CTO body,
Yeah,
we would have loved
yeah,
that there was no
yeah.
curve.
You're right.
It was a normal curve only, so that you can walk more straight.
Yeah, but in the situation to get in CTO occlusion, the CTO entry, there is a space. So anyway, we need second clamp. Okay, this is short. Okay, this.
So that extra bend which helped us to get into the CTO body will be a pain for us now as we walk through the CTO
Yeah,
body.
no. Yeah. Second bend is helpful to get in CTO entry, but
After that it is a pain.
not good to
Yeah.
control the wire after that. So.
But the problem is now you cannot easily change for a microcatheter. You have to remove everything,
Yeah.
including IVUS, so
And I
it's
think
very delicate.
And at this point, I think probably IVUS requirement is not so much. So I think if one can control it very well, then
Okay, this one. Okay, so this position is better than before. So I will control this wire. Namaste.
even from the CT, the distal cap looked very blunt also. So it's difficult to get in.
Re-entry may be a problem. Only a small streak was
Yeah,
getting
but
up
we
the
don't know.
bifurcation.
Are you there already?
ちょっと外れてるね。
Just short.
No. It's the full channel.
But you could switch now and get the Sasuke on this one and do a parallel wiring?
Yeah. Okay. So. Okay, I will change the system. We don't need the IBUS anymore. So. そこ先だな。
で、くさびは入らないか。入るか。
8F が入るでしょう。Okay. We change the system. So put back the Sasuke a little bit. 入らない The extension wire. Okay. So now we put the IBUS catheter and the Sasuke into the 8-French guide. But in this situation, we can't use the trapper.
Yeah, because
So-
there is no space in the catheter left.
これ先生抜いた方がいいと思います。僕こっち持ちます。
ちょっとじゃあどうしよう。
はい、もちろんです。前だけ
So you have a 7 French system or a 8?
8 French.
8 French.
So we usually use the 8 French for the IBUS guide.
Still you cannot get a
So-
balloon inside
Yes, the same-
trapping?
Yeah. No.
But usually we can, but this time is the Sasuke and IBUS in the 8 French guiding. Even though the 8 French guiding, we cannot use the trapper balloon for this situation. So the Dr. Kato using the extension guide wire to remove the Sasuke.
So this is very, you have only maybe a centimeter inside and
Very
it's
delicate.
very, very delicate not to lose the position here.
Yeah, very delicate procedure.
And also not to advance it too much.
Especially when you cannot trap.
Yeah.
Yeah.
So we have masters on the table,
So
Dr.
the-
Nazu, Dr. Kato. So let me see how you manage.
So, so now we don't have a dedicated device for IBUS guide wiring, so that's problem. So the company don't want to make that the dedicated device. So I don't know, the market size is too small, so they can't make money, so they don't want to make that. But anyway, we need a dedicated
ちょっと
device.
先生、ちょっとだけ待ってください。すいません。OK です。
Okay.
But we could do the same by, is it now slipped out?
Yes, it looks to be getting pulled back.
あ、出ました。
Your wire is getting pulled back.
Oh,
This usually occurs at the time when your wire is free at the TUI post. Because the whole part you still have under the control, but the moment you find your assembly which you are pulling out of the TUI boss, the moment it gets out of the valve, that's the time when the wire has a tendency to collapse.
So we put the balloon for trapping. Okay.
you have a knuckle now.
抜けてますか？アイバスが、アイバスが、アイバスが、アイバスいいですか？
うん、
アイバスがまだ抜けてない。
あ、そうか、まだ抜けてないか。ちょっと待って。
What is this trapping balloon?
It's
Sabi.
Sabi.
It's come from the Kaneka is Japanese company.
Yeah.
In Japan, it's very popular, right?
Yeah, many years ago, the Boston Scientific had the same system. So now, yeah, but they introduced a new system for trapping in Europe. I don't know in Asia.
Yeah, it's the trapper balloon. We also have the trap hit,
Yeah.
but actually we can use any balloon.
Yeah.
But this special balloon has a great advantage. The advantage is that you don't need a wire over it. Second thing is it has a great pushability. Third is the length by itself will tell you that you don't go on fluoro, just keep pushing till the time your hub reaches this. So you can possibly do some part of your procedure without fluoro.
So today
Your wire has already made a bend there.
yeah, it's a problem. It's,
I think the wire got pushed at the time when you were pushing the trap, most likely. That is somewhat undesirable.
Are you using the Sasuke now again?
Sorry?
Will you
Yes,
use the
yes.
Sasuke?
We have Sasuke.
Okay.
Yes, Sasuke, yes.
So this is set up for dual wiring or parallel wiring over the dual loom catheter.
Yes, 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 yes. I will do that. Okay. Okay.
And it's
So
very
I will
important
try
not to
the,
inject contrast.
double wire technique.
Yeah.
Okay.
Many-
So
Many people who
I
are
will
not
try the
experienced,
double wire technique. for the-
they inject antigradely
So,
contrast.
So there is big
He
no
is
for the
not.
integrate this point at least. Whatever you want to see, inject
Uh,
through the
two
microfilter in the RB
one,
branch.
Guy next one.
So your second wire is Gaia next one.
Yes, guy next one. So if failed the parallel wire technique, I will switch to the IBUS guided wiring again.
Don't you
So I
think
will
you
try
can pass the SUO through the collaterals?
You mean a retrograde approach?
Yeah.
Yeah, yeah. This patient has many the channels connecting to the radio, so we can do the retrograde approach. But now our strategy, especially in Toyohashi, we have focused on antegrade approach again. So the already retrograde approach is widely penetrated. So now it's very popular. So that as an inventor of the retrograde approach, I'm worrying that the use of the retrograde approach is now 40% in European and Japanese registry. I think it's too much. So for the next step, we need the improved antegrade approach for further the progress in this area. So now we are focused on antegrade approach again. So I will try. Of course, the IBUS guided wiring is failed. I will switch to the retrograde approach, of course.
So this part is very clear. Even the most experienced persons in the world, they still will give an adequate trial for the integrate. Even though this retrograde appears to be sizable, and I think for those who are in the business of doing retrograde, it's probably not one of the difficult one, and so should rather walk in or float in through this, and this can be followed with a softer catheter. But I think the operator still wants everything to be done integrately, and even if the integrate nipple was not seen so well, it was good to take the help of the IVUS and puncture with a wire with slightly higher tip load, but now shifting to a wire with a lesser tip load.
We don't see fluoro? No, yeah.
So I think the LAO looks to be better working projection than the RAO.
So in the aerial view, we can see the distal bifurcation very clearly.
Yeah.
But the important things in the right aerial view to confirm the wire position, I mean the myocardium side or the epicardial side.
Yeah. So it's the good view from the aerial caudal view to recognize the vertical gap between the wire tip and the distal true lumen. But now we have to move the wire tip. We need the horizontal gap. We have to see. So we are now seeing the aerial view. Okay, check please. Okay.どう？こっちで合ってると思うね。
Now, his wire in the aeriocranial view is located at the top of the bifurcation. So maybe when we go to the diagonal, right?
Yeah.
So we can check now. No.
No. It's a 4-channel. Yeah, 4-channel or perforation. Okay. So back to a little bit. And, もう一回ちょっとちらっと出して。違うね。最初から違う。I change the position to the proximal. Okay. もう一回流して。Okay. Now.
Looks to be out.
So probably I dilated, expanded 4-channel or subintimal space. So the wire can go anywhere. So in this situation, we need the IBIS guide. So I will put the IBIS into the LED. So
Do you need a nucleus?
どうかな今もう入ってるからもうそれでいいんちゃうかな。はい。じゃあこれいくよ。
The first wire seems to be directed towards the diagonal. Is it correct?
Yeah.
Yes, yes.
So you could put the IBIS on this
maybe
first
the
wire?
First wire is in the 4-channel in diagonal.
Diagonal, yeah. So you will take the IBIS on this wire which is in the diagonal.
I will check the IBIS. Check using the first wire. So I don't know the IBIS can get in the CTO easily. どっちがどっちかな。これが first wire.
So IBIS guided re-entry or wiring within the occlusion is even more difficult than IBIS guided puncturing of the cap.
Yes, but depends on the situation. If the subintimal space is become very big, it's very difficult, almost impossible using the mechanical wire. So also the difficult using the stingray balloon. So it's a very difficult situation. So
yeah, it's likely with the ADR technique here to lose definitely one of the branch, the diagonal branch.
当たりました。ロックしてます。
あ、6000枚。ちょっと一回取るわ。OK。Now is the ibis is coming. Okay, so just after getting the occlusion, yeah, so already we're in subintimate. So we have to change the wire course at the very proximal part.
You repuncture
So
proximal.
This is what, yeah. This is one of the advantage of the IBIS guided body. So
And also the subintimal space looks to be relatively wide, and most likely because the loop went in.
Okay.
So we see the true lumen to the in the area of 6 to 10 o'clock.
いやー、そうじゃなくて、もうあれ持ってった方がいい、距離が。
So Dr. Kato is now pulling back to find the space where the wire deviated from the true lumen to repuncture at that position. Will you try again the technique with the Sasuke on the wire, on the same wire?
No. Already the IBIS in the CTO body, so I'm using the これどうするかトラッパーした方がいいかな。まあいけたよ。Using a Corsair.
So already we can get the proximal cap with IBIS guidance. So actually the orifice itself is a true lumen, but the wire is very easy already gone to the subintimal space.
Next one.
Very proximal to the CTO body.
So with which wire do you want to work now?
Gaia next one, because we have already. So I will try the Gaia next one. If possible, I will step up. We have to go to the 7 o'clock on the IBIS. So of course we need some second bend because the proximal part has just some space. So okay. I need a little small scan curve.
So we often use a Conquest or Confianza type wire for this penetration.
Yeah, it's the Conquest type. The guide wire has a very ball tip chip. So it means that's why they easily slip to the distal. So we need a very sharp the guide wire to get into the tissue. So for that purpose, the Gaia Next is better than.
How about the Conquest Pro 28?
No, it's the same. It's a Conquest itself, the chip load is very hard, but the issue is the chip of the wire. So Dr. Kato already mentioned is the chip of the wire had a little bit big and slipy. So even though the chip load is very high, Conquest 820 very easy to go to the subintimal space in this situation. So getting the tissue, getting the true lumen is very important. That's why he needs the sharp wire chip. So Gaia next one, the shape of the chip is more sharp compared with the conventional guide wire.
So we should get the IBIS and the fluoros. We should get both fluoro and IBIS presentation now. We don't see the IBIS. Yeah, now we have both. So the wire is already pointing towards 8 o'clock.
It's very, let's say, even 10 o'clock.
The target is at 9 o'clock or 8 o'clock.
そうちょっと待って入ってないってことね
そっち方面ですね。
OK ちょっと待ってちょっとねワイヤが見づらい OK であれが数であれ今9時
いや、ちょっと見えなくなっちゃいました。どこや。今来ましたね。あれで6時から奥行きます。今入ってますね。
今入ってる。
はい、入りかけてる。So now is the second wire is getting is the two room and you can see the second wire is around 6 o'clock. So his second wire is now getting the two room and.
I hope so.
Yes. Yes. ちょっと押しますよ。ちょっと押します。はいはい。Now maybe you can see the second wire is 7 o'clock inside of the.
Yeah, we see.
Inside of the room.
Okay. So I will bring the Corsair deeply to get more support. Okay. Okay.
Yeah, we see it in the center of the vessel here. That would be ideal.
Okay. So now the tip of this wire is correct position. Okay. もうちょっと奥にはいけない。
ああ、行きましょうか。
Okay, それで待っとって。どこに行ってる今？見えない。ちょっと引いて。
今まだ行きますね。ちょっと奥行きます。奥行ってます。大丈夫です。ガイド大丈夫ですか？システム。
ちょっと待ってな。
押してるから。今はちょうど見えない。
ちょっと待ってな。ちょっと待ってな。It's a very dedicated procedure, so take time. So now is tip of the Corsair is in the true Roman. I was ちょっともうちょっと引いて。いける？
はい、これですね。今。Now is the second wire, the 6 o'clock still inside in the intimer.
So you advance the Corsair behind already, and then you will switch wires, or you will try with this one?
Now, yeah, it's one of a choice. Okay, go to this row. This row.
アイバス？
ちょっとだけ。
あれを見せてもらっていいですか？ちょっと外システム。
Okay, already out. So I will change the wire. This wire is too sharp, so I will advance the Corsair into this plug. So okay. So XTR too, right? I will switch to the XTR. I will show the position of the Corsair. Can you see?
Yeah.
we already confirmed the chip of the Corsair inside the Intima.
But the second wire advanced rather deep now into the first wire, I mean, with the knuckle. It has a high risk of dissecting this diagonal.
Yes, it's a problem. But if we can get the true lumen at the bifurcation, probably the dissection created by the first wire is not so big issue. So anyway, we put the stent there.
So you are now using a very soft taper tip wire, but still I think the distal cap could be a problem because there's a lot of calcium.
But from the CTO findings, there is no calcium disturbing the wire control at the distal end of the CTO. So I hope this floppy wire can negotiate the vessel. Soこっちでこれ横に行ってしまう。こっちで見ると離れていかないといけない。それに近づいていかないとね。いや、本当はだからあれから見るとパラレル。だからvertical position it's okay, but horizontal position is not good.
The wire is a little bit eccentric inside the vessel structure.
I will check the injection. Okay. No? No?
So we see the wire now at 4 o'clock.
Yeah. So I wasちょっともうちょっとコントロールしてくれ。
Maybe you just penetrated into the wall, but not into the central plaque.
進めた？どう？
もう今ワイヤーを変えてきちゃってる。入ってきてんじゃないですか。これワイヤーじゃないですか。
ちょっと待って、低度。
違うわ。全然違うわ。もう先生もうパワーすぎて見えないです。もうダイアグナルに入っちゃってるから。今これはワイヤーギリギリ中にいいんじゃないですか。
いやもうちょっとディスタンス。ごめん、プロキシマル。プロキシマルに行ってます。プロキシマル。コルセア見える？
コルセア見えてます。これ大きい鍵がコルセアだと思います。
はい。出てきて。
今コルセアが。
コルセアの切符を一番手先。
これ。ギリギリ中に入ってると。
OK。そしたら。
So you analyzed and the Corsair is not.
On the Ibis, the tip of the Corsair is in the interplug. So I will change to the Gaia next one again. I need better controllability. So okay.
So you're within the vessel, but you're stuck in the plug.
Yeah, stuck in the plug. So it's good. So it was difficult to control the XTR. So I switch to the Gaia next one.
So do you remove the secondary shape or you add a secondary shape? What did you
No,
do with the
it's,
wire?
They've
I
taken a
just
new wire,
changed
added
the angle of the first wire, the first curve. So because we need change the route just after the tip of the corsair.
So you're shaping it the same way as it was done the first time.
Sharp end. Yeah, I did the shape.
Same shape.
So the wire is outside again. So you need to repuncture.
The position of the tip of the corsair is maybe too deep. So do. よいでね。
それワイヤーじゃないでしょ。見に行きます。
見に行って。ディスタルに。
今どこ？あ、先生これまだもうすでにホースですね。どこ？今4時。もっとこっち側に行かない。
本当。こっち側に。ということはもっとこっちか。
まだホールスですね。
まだホールス。
ここはトゥルです。ここトゥル。
ここトゥル。ディスタル行って。あ、OK OK。Now is the back to the interprime.
ここでサブに出て。ここで出そうになってる。ここで。
それディスタル？
もう今ちょっとディスタルってました。
OK。でこれは？
もう出てますまだ。いや出てますね。そこ見えないです今。あ、今出てます。
出てる。はい。
Are you sure that it has penetrated? No.
Control this wire. No, just tracking the vessel.
Yeah.
So now is the wire tip is inside the vessel. ちょっとディスタルにして。
今これ見えないんだよ
な。The problem
でも
is
今多分中にいますよね。今中にいます。今中に。
Problem is we can't see the distal part. Okay, injection show. Injection. Because of the calcium. Yeah. Okay. So I will use the anti-glide to this moment. ちょっと出たかな。はい、じゃあもう一回。はい。
Very close, but
Yeah, it's very close.
in the other
じゃあこれ
projection,
ちょっとこっちクラニアル振ってみて。Yes. クラニアル。で、RA ビューだけでいい。撮影は。Okay? Okay. So.
ちょっとだけですよね。
Okay. はい。Yeah, from this view, it looks good.
how is the response of the tip of the wire? Looks like it should be released if you are through.
I don't know. I will check. No license. And there.
Yeah,
No.
yeah.
That's,
Yeah, usually if you are through, the wire should flow through, and there seems to be a lot of resistance still.
Yeah. But to get in true lumen, we have to anyway penetrate the tissue. So okay, that's it.
But you are very close, so would it be not the easiest thing just to bring a parallel wire, a stiffer wire? Because
yeah,
you're...
okay. So
I don't know how long the transmission will last here. We're just almost at the end of the prefixed time. So what are your strategy?
Now we have to, we should move to the retrograde approach. So we don't need to spend much time. So, yeah, 拡大やめて、拡大。Okay, for the retrograde approach, the easy route is collateral from the circumflex using the PL branch in the circumflex. So I will show the collateral channel. Okay, injection. このガイドからのインジェクションですね。あれを見るだけでいいよ。で、全体こうなる。
So it's important. It looks so close, but he doesn't pursue because he feels he is in the wall. So it would just cause huge dissection to proceed here.
Hi. DTS.
Also going retro will ensure that you are able to preserve the diagonal.
So, Dr. Berman, the Canon Medical asked me to explain about the DTS system in their X-ray system. So maybe you can see the DTS,
yes, we see
simulation image. Yeah. So the fluoroscopy time is now I can see.
Both is almost 15 minutes.
15 minutes.
But front.
No, 23 minutes.
Yeah, 23 minutes in the front one.
Yeah.
The lateral is 28.
28.
So totally the photo time is around 50.
50, okay.
But our radiation dose is 1.8 gray.
1.8 gray. But in the DTS, its skin dose is very low. So you can see the blue indication. So it means around there, the max dose is 851 milligray. So 0.8 to 0.9 gray. So in Japan, we can use this system routinely. So this system is useful to avoid a hot spot. Recently, this system is very precise. So in the past, this system is not so precise. So the indication of this system is not reliable, but now it's very reliable. Is that okay? So we have no time.
No, probably we'll have
I will show the last angiogram to show the collateral channel. Okay.
Yeah.
Now it's not clear, but most distal PL branch connected to the diagonal branch. So I will use this channel.
So the channel we don't see, you will take.
Yeah, maybe we create the hematome to the distal. Maybe, yeah.
Okay, we are pretty sure that you will finish this case successfully with the retrograde approach using one of the channels.
Yeah.
And I think thank you very much for transmitting this interesting case with a new aspect of dual lumen catheter on top of the IVUS.
Yeah, same bar.
Thank
Same
you very
bar, yeah.
much.
Thank you. そしたら、これはもういらない。
So
アイバスだけ置いときたいので。
shift to the next session. But before that, Corona Namaste to everybody. When I came here, I saw everybody shaking hands. The time has come for us to say Namaste to all, because in Corona season, it's a time to reduce 50% of the infections if we go to a no contact policy with that. Interesting session for the next 1 hour. We have
So,
interesting session covers all aspects of regulatory and medical legal aspects.
もうかなりもうコラプスしてて。
One line to summarize the whole session, and that is when we entered our medical college, we were taught to be scientifically correct.
患者さんもちょっと苦しい
And
やろ
then came, no, you need to be morally correct, ethically correct, regulatory correct, and legally correct. So we will be covering most of these sessions. The first speaker is not there. We'll directly move to the second speaker. Cost offered for cardiac intervention procedures in public schemes in India, are they reasonable? An issue started after Ayushman Bharat, when government covered almost 40 crores of the people, 40% of the population they covered, and they brought down prices which were not accepted by the medical profession in many instances, specifically talked about cesarean section for 9,000 rupees. Let's listen to Dr. K. Parikh from Ahmedabad on this particular subject. The cost analysis of schemes offered by CGHS and by Ayushman Bharat.
Good morning, everybody. And my disclosure is I have nothing to do with government agencies. I know the respected Prime Minister personally, but this will not influence my talk. As you see, in 10 years, we are going to have a dramatic shift in the payer mix with practically entire Indian population will be covered, and rightly so, because that's the responsibility of the society to ensure the populace with healthcare, a roof, food, and education. Ayushman Bharat is a seminal event in Indian healthcare delivery, and it was a major decision, very positive decision, and it brought in the entire 30–40% of population under healthcare delivery. It includes outpatient visits, in-hospital stay, physician fees, implantation fees, medications, short-term and intermediate term. So I'll come to the point. What are the major challenges in this new cost parameter which has been established by the government? And the topic I was asked is, are they reasonable? Now, I'm an interventional cardiologist by heart, but I'm also partner, chairman, significant owner of a hospital in Ahmedabad, CIMS Hospital. My managing director, Milan Chugh, is right there in the front too. He is even more of a cardiologist than a managing director. I have been made to become both interventional cardiologist and a manager, like Ashok and many of them have become. So let's talk about the cons, the negative side of this entire huge enterprise which has come. The angioplasty coverage under this Yojana, only 70–75% of the total cost, not even the pricing, is covered. Now in India, private healthcare provides 60% of the healthcare delivery. So already it is creating tremendous negative impact, where a cost of delivering healthcare in angioplasty area from 90,000 to about 1 lakh rupees, the cost. the amount provided by this Yojana is 75,000. And if you look at a single set stent packages from 75,000 in the Ayushman Bharat to on the right side, the yellow column of a city, Bangalore, Mumbai, NCR is 1.5 to 2.5. This is the charges, not the cost. Is almost double, triple in many places. And if you go across again the left, black Ayushman, and then various state schemes, some of them are terribly underpaid. Somebody told me that Samin Sharma's Eternal Heart took the Bhamasha Yojana for 1 week. 1 week, the shortest period anybody be on the scheme. And you can understand 54,000 for a package including stent. Same goes with bypass. Now, are these sustainable? The answer is no. With the medical inflation, cost inflation, material cost, manpower cost, if you look everything, there is a significant downside EBITDA impact. EBITDA is earning before interest, tax, depreciation. And this will reduce, only see that figure in red, 60% return on capital employed. So this is a significant reduction. And this will lead to significant degrowth of major centers in India who are providing quality care. If you look at these numbers, 120, let's say, is the non-scheme patients, routine insurance patients and regular paying patients. In the yellow is the scheme patients, Ayushman Bharat scheme. As you increase, just look at the last column, the return on capital employed starts dropping significantly. And if you start putting the cost of land, this is not even with cost of land, this is cost of hospital without land, it becomes significantly negative. Same here, just look at one topmost left, ARPOB is average revenue per occupied bed, don't look at everything else, goes significantly down. Now, so the challenge with existing packages are not adequate. There's lack of guideline-based therapy, no separate package for follow-up, diagnostic procedures, appropriate physiologic assessment are not there. There are significant costing anomalies and no technological advantages. So significant negative side. This has led to word of mouth. I don't have the proof, nobody has the proof, but the proof will come out. Reckless use of procedures now. Majority of the healthcare, either if given in private sector, have to bring their returns. There's no way they are going to run this with loss. So overuse causing in significant rise in healthcare cost. And I have myself personally reviewed some in-stent restenosis cases where the original lesion was 40-50% with the underfilling of dye, an intentional fraudulent criminal behavior by cardiologists where they underfill the artery to create a much more visually looking lesion. And this is especially true for middle income groups trying to utilize the government scheme. So there are two sides of the fraud. One is the patient fraud and the other is the doctor fraud. So what is the pros? Pros is that it was supposed to be for landless people, SC/ST household, Kacha household, female-headed. And if you look, residing in one room, disabled members, scheduled castes, destitutes, manual scavengers, phenomenal population who are very much below poverty line, rag pickers, beggars. Are those the people who are getting this scheme? Are we as doctors reporting them that they are fraudulent? So 100% both sides are at fault here. So in conclusion, Ayushman Bharat is targeted at poor and vulnerable families. It's a tremendous scheme, but the scheme likely to create further negative impact because many affordable patients predominantly are using this scheme, which is a burden, and government is keeping a blind eye for whatever obvious reasons. Last line, which is kind of hidden, it would be mandatory to include AUC. People who don't know, AUC is appropriate utilization criteria. In America now it's criminalization if you do not use AUC, especially in blocks below 70%, if there's no FFR1, you are criminalized, your rights are removed, and doctors, including cardiologists mainly, have gone to jail for that. What will you have to do in last 2 slides or 3 slides? We have to drive efficiency to evolve optimal variable and fixed cost for everybody. Material cost optimization, material consumption optimization, clinician payout optimization. Let's face it, in America, the doctors form less than 5% component of the hospital package. If we talk about this here, people will laugh, it's a joke. Doctors don't agree and they jump hospitals. Doctors will have to temper their expectation now. This is a good model for tier 2, tier 3 cities where the cost is much less. Make in India, terrific decision. It will increase the innovation in India. Government policies should include elite bodies of cardiologists, including practicing doctors. And finally, it should be mandatory to have AUC. Last slide. Those not participating in these programs, companies and hospitals who want to create their uniqueness will have to strive to stand apart through intensive patient-oriented program to capture non-PMJ, non-Prime Minister Yojana patients who will be selected to go to exclusive hospitals such as JCI-approved, extreme high-end quality hospitals. So again, 2 things will happen. Hospitals will have to improve their standards. Government will have to bring in lot of criteria, including second opinion, all intervention to non-member cardiologists to see if this was rightly done with a very nominal cost, 2,000, 3,000 rupees. And it's my consulting fee charge. And finally, everybody will have to improve. Thank you very much.
Thank you very much. We'll have discussion at the end. And let me now invite another important aspect, both which is... Okay, Dr. Trehan wants to have a discussion. I only want to have one...
I think we can have 5 minutes. I think we have time.
Okay.
And I would like to open the forum to questions.
I'd just like to...
I have answers for every question.
No, I think
Whether the
that
answer is correct or incorrect, I don't know.
It will be much more important to interact rather than be didactic.
So I only want to say
last
one
case,
thing. I want to
Dr.
make a
Kato
comment.
showed. Dr. Kato showed the last case, and we left in between. And if you look at, there was a guiding catheter on the right side. There was one wire on the RV branch, conus branch. Another wire was there deep in the right coronary artery. There was a microcatheter in the conus branch. Then he started with 2 wires into the diagonals. Then he had a microcatheter in the diagonal. Then he had a state-of-the-art IVUS catheter on the side branch. Then he had 2 wires which went into the main vessel. And then he ultimately again shifted and wasted 2 more wires there. And finally he thought, nothing can be done, now we'll go retrograde. Let us know how will people in PM Yojana be handled in such difficult situations.
Very good. I totally agree. And that's why the con is...
Second thing is you are asking about the aspiration of the doctors. How will you link this kind of a procedure vis-a-vis straightforward angioplasty which is finished in 5 minutes?
So 2 answers. First is Prime Minister Yojana will not cover, and that is in my cons, negative side. No technological advance. There is no appropriate utilization criteria, so anybody will do anything. So I'm agreeing with you that this kind of cases, not only this kind of cases, they have not differentiated complex, non-complex, they have not differentiated physiological, so I am with you, number 1. Number 2, the issue of reimbursement in complex cases. Again, I'm agreeing with you that there is no arrangement. But what I'm trying to tell is, since 40% of population is covered by this Yojana, insurance are following these schemes, they've cut down. I'm not justifying. What I'm saying is doctors will not have a choice. It happened in America when I left in 1995. I started in angioplasty in 85 with $3,000 package for a doctor in America. When I left in 95, it was $1,500. Now it's $300 to $400. Do doctors there have a choice? No. So I'm agreeing with both of what you are saying. What I'm saying is the scenario will change and we'll have to accept the doctors as well as the system.
I want
That
to
is all
add a
right, but
comment.
Next
the PM Yojanas are basically like Antyodaya. Those who are the most needy person, they should be given.
Absolutely.
In coronary disease, the most needy persons are these, who have the worst of the anatomy, the cheap patients. And if we are addressing only to the pussycats and just giving them simple treatment, that means this will be disincentivize those operators who will be handling such cases.
So I'm not defending.
You're not giving them money. You're
Dr.
not giving them the hardwares.
I'm agreeing with you. All my cons covered those.
People will stay hungry only.
I want to add one. When I was the national president of Indian Medical Association, we appealed to all the medical associations, which I'm also appealing to CSI, if all the doctors collectively decide, because today, after PMJ, after the Pradhan Mantri Yojana, there is no poor person, because poor person is covered by the government. So therefore, whatever free work we do is not justified. So all our economy ward patients, that means in a hospital, we have 100 patients, 10 should be reserved for economy ward, and they should only be reserved for PMJ types of patient, where the government pays. So our free work should stop. Even if the insurance company says that you have to do in this particular thing, we have to say he has to go to a general ward, not a private ward. If all of us do that, nobody can dictate us. So if all of us do 10% of our so-called CSR work under PMJ, the number of beds at a pan-India level will increase, but that has to be taken by a decision by the association, not by individual hospital, and not by the government. But that will give a solution for that.
I'd just like to give one comment. I think, Dr. Parikh, you mentioned very rightly that time has come. We should not be dictated by the government. We must have a strong body, and we should dictate what should be our charges. All the charges are laid down by the government without taking into confidence the society like CSI. I don't think anybody is taken from the CSI. How they decide, who decides, is it the IAS officer decides? We don't know. Number 2 point, which you mentioned about, that the payout of a doctor is only 5%. 95% is to
USA.
In USA. Yeah, I think we need to understand that doctors are the intellectual people, everything is done by them, and I personally feel we have to intervene in advocacy and in policy making at the level of CSI, which control the area.
Let me thank Dr. Parikh for this wonderful session. I think the time is up. We'll take it back after the... I know. Yes, okay.
I mean, is there a possibility that if suppose like your hospital or my hospital, where we are finding it difficult to treat the patients at CGHS rates also, so can we refuse this Ayushman scheme, or is it compulsory for everybody to?
No, it's optional. We took CGHS for 1 month, the shortest in Gujarat by any hospital. We refused after 1 month. We are not in any schemes. We are 50% direct payment versus insurance. So it's a voluntary. From foreseeable future, I don't see government enforcing this.
Ayushman also will not.
Yes, it's not enforceable future, but if they force it, they force it. Government can do many things. You can't fight the government.
Thank you.
You can
Dr.
try
Parikh.
to work with them, but it's difficult to fight.
Thank you.
I
Thank
think
you,
we
Dr.
stop.
Parikh, for a wonderful, let's give him a big hands. Another important thing which is also linked with the Ayushman cutting of rates, because when you want to cut rates, when you want to provide and bearing a cost which is not beyond your control, you end up in reusing catheters. Are they valid? Are they allowed? Are they not? 2 years back, CSI brought out an article on this in Indian Heart Journal. When I was in IMA, we also brought out a white paper that in which situations we can reuse of a catheters. Let's listen to Dr. Aditya Kapoor from Lucknow. Should it be permitted, the reuse of select cardiac devices in India?
Morning, everybody. First of all, thanks for giving me this topic
promises to be very interactive, and a lot of opinions I'm sure will be generated. So I thought I'll just divide it into various segments, and we'll move as we cover all these topics. Single-use device, we all know, is one device which is designated only for one-time use, because the manufacturer actually thinks that doing so repeatedly may jeopardize its integrity. And the responsibility for designating a single-use device lies solely with the manufacturer. It does not, however, imply that it cannot be reused if it is appropriately reprocessed. I'm using the word reprocessed, because the manufacturer has not provided us any data that the device cannot be reused. The authorities in the West do not have any pre-market assessments to determine if the device can actually be reused, so the manufacturer's word is sacrosanct. It has happened in the West, this is documented data, that manufacturers have often changed label from devices from reusable to single use without significant change in their design. In fact, sometimes the manufacturers themselves have given their own reprocessing instructions, questioning the relevance of a single-use designation and, of course, the necessity of complying with it. So what exactly is reprocessing? It is completely different from reuse. Reprocessing is a standard, tested protocol-based cleaning, disinfecting, sterilizing, and testing the functional integrity of the device with assured quality behind it. So it is completely different from reuse. Because if we have an unregulated reuse, we have obvious concerns which are valid: infection. The cleaning material may damage the device, compromising its functional integrity, and of course legal and ethical issues. The benefits are obvious. One is the cost, because the rising cost of devices has often prompted us all to reuse these catheters, especially relevant for our Indian patient population, so that the procedures and the devices can be made accessible to a larger chunk of patients. If you look at data from the West, across the last decade or so, millions of dollars being saved in the US by reprocessing, and now the reprocessing industry has gained a firm foothold in the West in terms of revenue generation. And this is data from Germany as well. So enormous cost savings. And another advantage which we forget is huge reduction in the toxic biodegradable waste. So it can improve the environment-friendly footprint of the hospitals, and if at all we engage with the regulatory agencies in terms of this, as Dr. Agarwal also mentioned rightly, we can discuss about the government's Swachh Bharat Abhiyan also, because it is in sync with that policy as well, if used correctly. What about data from the West? So in the developing world, it's only been in-hospital units which are reusing in a non-standardized, non-protocolized manner. In the West, it is a strict industry. And if you look at the US data, this is the reports published in 2000, which said about 1/3 of the hospitals which were being surveyed, they were actually reprocessing, and there was no significant increase in adverse effects. But it said in 2000 that although there was no evidence of harm, there was more regulatory oversight which was required. So the US improved its laws, and this was the law which was passed in 2002, which clearly says in US also that if a single-use device is being reprocessed, it has to be labeled as reprocessed, and the name of the reprocessor has to come on the device, so that the ultimate liability is with the reprocessor. It is not with the original manufacturer. Another report by the US in 2008 again said there was no causative link between reported injuries and correct reprocessing, and said that it was a good thing that oversight has increased, and available evidence did not indicate that correct reprocessing of appropriate devices posed a hazard to health. So currently, under the FDCA Act of US, reprocessing of devices marketed as single use is lawful, and it is also endorsed by the CDC. What about Canada? This was the landmark study by Policena in 2008. About 1/4 of the Canadian hospitals were reprocessing, and in 2014 and 15, similar to US, the reprocessing industry came under regulatory oversight in Canada as well. In the European Union, it is varying from country to country. Germany, Denmark, and Norway are allowing reuse. US and France, it is not legal. So third-party reprocessing in the West is stringently regulated. It is legal and has resulted in safe and good outcomes with enormous cost savings. The bottom line is regulated and legal. What about cardiology? So there are 3 segments of catheters which can be considered for reuse. Luminal catheters. Angioplasty catheters, the problem is adequate cleaning and ensuring the functional integrity of these fragile catheters is often not possible. So presently, given their present cost, perhaps a limited or no reuse of this segment. These are just, opinions. Which luminal catheters should be used? Perhaps BMV catheters, because number one, they are large lumen, they are more costly and easier to clean. And often we do these procedures for poor patients. And in fact, you look at government schemes, it presupposes reuse. Most packages for most schemes, as sir also mentioned in his talk, they presuppose reuse, because for BMV, the cost which is allocated is nearly 1/5 of what it would be if you are completely, using a new device. Solid or non-luminal catheters, such as EP catheters, are relatively easy to clean. Protocol-based reuse is safe, as shown by various studies in the West. It does not only save cost, but it has good quality assurance. And in India also, they are universally being reused, because using multiple 3 to 5 catheters in a patient would be prohibitively expensive. The third segment is devices. As we go up this segment of devices, they become prohibitively expensive. And often the long battery life of these current devices exceeds the lifespan of the patient in whom they were implanted in. So reprocessing is not a bad option. And again, this is published data, no increase in infection, mortality or device function. The first study was Rosengarten 30 years ago, then Dr. Balachandar published in 89 in the Indian Heart Journal, subsequently Yash's data, Mexico, and recently Raja Selviraj published from South, that if refurbished or reprocessed is the right word, devices were used in a good manner, there was no incidence of increased malfunction, infection, etc. So what is needed in India? Perhaps we need, every hospital should have its own reprocessing or reuse committee, which should be multidimensional. It should have doctors, infection control officers, microbiologists, nurses, administrators as well, have written protocols. The central reprocessing unit has to be very, very well equipped. We need to have a periodic review and audit, which is very, very lacking in India. So random checks, microbiology testings have to be done. If there are any incidents, they have to be reported and retrospectively analyzed as to why they happened. Very importantly, maintain a record of the number of the reuse and discard the device after the intended reuse terms are over. These are again just suggestions. I'm not saying that it should be done, but it is possible if we all get together and do it. And the hospital and the reprocessor has to take full responsibility and be accountable for the safety and efficacy of the procedure. So this is again an important thing. Which single-use devices should not be reused? So again, that is an important thing. All devices cannot and should not be reprocessed. One which cannot be cleaned adequately, whose sterility cannot be safely demonstrated, and whose integrity and functionality is compromised. So all these things have to be completely tested before you do a random reprocessing. For pacemakers, devices, only if there is adequate battery life, and device interrogation should be done prior to implant in all cases. Of course, consent is another issue which I will not touch upon because of brevity of time. So if you look at our guidelines, 2 consensus statements have been issued about 20 years apart, in which again it was said that strict adherence to norms of sterilization have to be there. So I'll just end with what is the current status when we have engaged with the regulatory agencies about it. So this was an RTI which was filed to the CDSCO in 2018. People wrote to the agencies that what is the standing of the agencies, and they clearly said that reuse of single-use devices is not under purview of the Drug and Cosmetics Act. Hence, it is not regulated by this office. So there is no legal law which is supporting current reuse. So subsequently, Maharashtra was one of the first states which said that one needs to engage with the center regarding this. Subsequently, Maharashtra FDA wrote to the ICMR, and ICMR met in 2018 and said, it issued a draft statement, said that reprocessing or reuse, if it is to be done, good quality, good safety and good efficacy assurance has to be there. Adequate consent has to be taken, and very importantly, ensure that the economic benefit of the reprocessing procedure passes on to the patient. The patient is actually not billed for it. Or the government has to reduce the price of catheters. I think Dr. K.R. Parekh also mentioned, Make in India initiative, so the cost comes down and we obviate the complete need for reprocessing or reuse. So I'll finish off with this. This was the latest statement from ICMR 2019, where they clearly said it is environment friendly, it is cost effective, provided you pass the benefit to the patient. The term reuse and reprocessing, they are not synonymous. So for reuse, which is not standardized, not protocolized, it should not be done. It is not ethical. you might want to engage with the regulatory authorities that reprocessing is the way to go forward. So in-hospital or third-party reprocessing units should be encouraged. We need approval and supervision of the regulatory agencies in that. That is the key point. Last slide is this. They should not be billed obviously to the patient. The economic advantage has to be passed to the patient. Our society needs to probably conduct more studies. And we have to have a Make in India initiative for either catheters, or this is a new thing which IIT engineers have come up with, Incredible Devices Solution. This is a company which has come up with a cardiac reprocessing sterilization system, which they are marketing, and I think all of us should probably try and talk to these guys whether or not it is feasible. It is good because people have been using it. So economic and environment friendly approach, and perhaps in the current scenario, we probably need to engage with it, engage with the regulatory agencies rather than shy away from a good, legal, stringently regulated reprocess. Thank you.
Dr. Aditya, thank you very much. I think this was a very, very difficult topic and you have covered almost every aspect of it. Now let me just ask you one simple question. There is a doctor engaged either in the government sector or in the private sector, and he caters to a patient who has a mitral stenosis, and patient is sick and you handle that patient. Most of the patients are young, and this patient undergoes a procedure and successful procedure, and sometime later this patient comes with an allegation that you have given an HIV to me. Not the best way to get it, but you have given the HIV to me. Now, where does the doctor stand? As far as the court of law is concerned, he'll be summoned and he'll be left alone to defend himself. There will be nobody from the administration, nobody from those people who have fed whatever information to those who have made these PM Yojanas and set the prices. Now, what is your suggestion? And this same question is, I think, if you are not able to answer, to Dr. Parikh.
Yeah, I'll attempt to answer.
Dr.
KK.
I want to add the question. I want to add what Dr. Trehane said is that the original thing came from Anuradha Saha case, where 12 crore compensation was given against the doctor and against the hospital. And the case lied only on one line: manufacturers' adherence, their recommendations were not adhered to. That's all. There was no consent taken. Manufacturers, whatever manufacturers said, because you violated that and no consent was taken, 12 crore compensation was given.
Mantosh, you want to ask?
Yes, that is very important. 1995, when I was the President of Cardiology Society in India, Dr. Sharma, the President-elect. So we that time make a regulatory body on behalf of CSI, and on the guidance of the retired judge and their committee have permitted the use of these things. Of course, they mention some indication that infection, regulatory things, patient will give the comment that he is taking the free in cost, not for sale. And litigation company will mention that there is no litigation on behalf of the company. So on that thing, 550 cases use of pacemaker already published in Indian Heart Journal 96. I have done it. I presented SFSB conference also. Everybody appreciated also. So to the whole world, Canadian registry of the pacemaker and the devices of the ICD, they also approving it. So that
Thank you very much, Dr. Aditya Kapoor. I think let's give a big hand for your most outstanding presentation. We are paucity of time, so we'll go ahead. I think the next speaker and the next topic is medical legal issues for interventional cardiologist. And we have the most eminent speaker who is a past president of IMA. And no medical legal issue is complete without Dr. K.K. Agarwal. I present to you, ladies and gentlemen, Dr. K.K. Agarwal for his presentation.
Thank you, Dr. H.K. I like 10 minutes of silence because matter is important. Over one case is being filed in various critical medical councils every day, and lots of cases are filed against the cardiologist. I will give a simple one-line situation, then I will try to find what the laws are, and then I'm trying to say how to defend in this particular situation. Say 56-year-old female, 2 a.m. in the morning, she came with atypical chest pain. ECG was non-conclusive,
At 2:10, after 10 minutes, the tropi report was available, was negative. At 2:15, echo was done. The echo did not show any significant wall motion abnormalities. At 2:30, she had ST elevation, Dispirin given. 2:45 taken to cath lab, LED 100%, stand put. 6 o'clock in the morning, she had VT-VF and died. Standard picture, it happens. Everybody has seen such cases. Allegations, echo was done by a junior. Why a senior was not available. Chances of death were not told to us when she was admitted, that she can die also. We were not given an option of thrombolysis versus cath. What are the chances of death? Why Dispirin was given after half an hour? Why it was not given at 2 o'clock when the patient came with chest pain? Why it was given at 2:30? Why, when the angioplasty was done by an associate and not by the senior person? Blah, blah, blah. These are and the type of stents were not told to us. What are the options available? Now, these are the types of questions which are coming, and we need to defend them. Okay? Let's go. How to defend these types of situations. Can we have where is the? So I'm going to come back how to defend such a complaint, initially, generally, and I'm trying to answer all those situations. First of all, either you accept your mistake or you deny. If you accept, you say, I plead guilty, your punishment is less. All over. So either you plead guilty, okay, or you say, I deny. 99% of the time, people will say, I deny. So once you have denied, you say, first of all, you say, the respondent has not come with a clean hand. That means he is telling a lie, or somebody is instigating him. That's your first defense. The second defense is, remember, the burden of proof lies with the complainant. Now, this complainant has given 6 questions. You need to answer only those 6. If an expert is finding out, oh, you 6 are fine, but you did a 7th mistake, that's not allowed. So an expert is not allowed to talk about that 7th mistake has been done. It is for the complainant to come back and say, this was the allegation. And here we do a mistake when we go as an expert. यहाँ तो नहीं है, ये गलत किया है. That's not our job. Finding mistake is the job of the complainant. That's the law. In the bottom, I'm not reading. Everywhere there is a reference. First of all, you have to show that I am a professionally competent person. Okay, that's your first duty, to show that I am professionally competent, that I am qualified doctor, these are the degrees, I've received honors, I attend India Live every year, I have been a panelist, I have been a speaker. So everything you have to, whatever possible, you declare that you are competent, and my junior is also competent. So once you say my junior is also competent, you say we are equal. So who is a competent? 50% marker, not the 70% marker or 80% marker. Jisko 50% marks mile, he is competent. So my junior is also competent. That answers 2 questions. The junior did the echo, junior did that, and there is a Supreme Court judgment talking about the juniors as good as seniors. And then 8.6 says, MCI talks about that if junior is incompetent, then you are responsible. And that is very, very, very clear. Now, second thing you have to prove is, I am scientifically correct. How do you prove that I am scientifically correct? You say, this is the book. This is a textbook where it is written, my approach was correct. You say, this is the journal, which is the latest. You say, I attended this conference, there are the experts, there are the abstracts, that in this conference, Dr. Seth presented that and I followed him. Okay, therefore it is important for you to keep those abstract books. You say, these are 4 experts who says, you are all right. You say, these are the testimonials. Testimonials means they have gone through my case history and they say you are correct. You say, these are the guidelines. This is India Live guidelines. I followed that. You say, this is the current practice. Now that answers off-label use of catheters. You say off-label use of catheter. This is the prevalent practice. Everybody does it, so I am not tolerant it. So therefore, this is a prevalent practice, current practice, published in Indian Heart Journal, or done in Calcutta, the CSI brought out this guideline, so I'm not at fault. So if you can prove them, any one of them, you're fine. Then you say, remember, 3 essential components of a negligence. There has to be a duty to take care. There has to be a failure to attain the duty. And the third is damage. If no damage, no negligence. You say, ultimately, I ended up in the patient has been saved. So no damage, no negligence. So there was, you say, I did not deny the existence of a duty to take care, but there was no breach of duty. I have treated the patient as per general and approved guidelines. Experts' opinion have testified the same. Always, whenever there is a complaint, go with the answer with 3 or 4 testimonials of your colleague that you are all right. Because in the council or in the court, medical experts may not be there. So you go back with testimonials. I did my duty with a reasonable skill and competence. It's important. You need to be 50%er, not the 90%er. You are only required to have a reasonable skill and competence of a person of your level. MBBS ka MBBS, DM ka DM, MD ka MD. That level, minimum skill and competence. Therefore, I have done nothing that any reasonable doctor would not have done, or I have refrained from doing anything which a reasonable doctor would have done. Omission and commission, you prove. I acted as per my best decision, Difference of opinion and error of diagnosis are not negligence. If some doctor doesn't agree, I don't care. As long as literature shows, I never gave any assurance or a guarantee. So in this particular case, I never said ki theek ho jayega. I observed all the precautions and adherence to all the guidelines mentioned in Supreme Court judgment. So there are 6 guidelines given. I did not disobey them. I cannot be liable for an advance service which was not available in the hospital at that particular time. And this was an emergency. Whatever catheters and stents were available, I put it. That's the answer for that question. Because you say that you could have gone for another stenting, another type of a stent. You say it was an emergency case. Whatever was the best option available, I did it. I did not waive off the fee. Never waive off your fee. कि पैसे माफ कर देंगे तो केस नहीं होगा. That's not correct. It was a complicated case, and in these situations, the doctor must get benefit of doubt. You say this was a 2 o'clock in the morning, this was a complicated case, female, we were not expecting women में heart attack कम होता है, and we did best of our knowledge. There was no deficiency of service. I did not neglect the patient. I did not delay the treatment. You said aspirin was not given for half an hour. You say the guideline says at the time of suspecting or diagnosis, you must give aspirin. So TROP-I, the time was 2:30 when the diagnosis of MI was confirmed, and I gave. At 2 o'clock when it was suspected, the guidelines say you can hold. I was not confirmed, so therefore I'd give it at 2:30. You have to prove out. And they will say, no, some doctor says that it should be given at the level of suspect. The time you say, some doctor says, you say benefit of doubt has to be given to me, that means there is no consensus. At every step, I explained the risk and situation and documented it. Now here we come back is 2 o'clock in the night, you did not document to them in great detail. Then IPC protects you that in emergency situation, these are not applicable. 2 o'clock was an emergency, my criteria was to save the life. That was first, and not to spend half an hour giving explanation about the consent. I have given them reasonable information. It was not a case of negligent or non-disclosure. I did nothing that overruled the manufacturer's recommendation. I have added the opinion of experts, and the court may prefer one body of opinion to other, but that is not the basis or conclusion of negligence. I acted in accordance with standard practice. I choose the line of management I thought was the best for the patient. When I treated the patient, the line adopted by me was the best option taught to me. There was no resultant injury. The complications which occurred are well described.
Whatever happened was a pure accident. This death was an accident. It does happen in the literature. Such an accident is well described in the literature. The mortality is well described. Immediate death is well described. It happened because of consequence of ailments. The very fact patient died does not mean negligence. No doctor can give 100% guarantee. Supreme Court decision. In emergency, this was the best I could do. In emergency, you always have a option to quit. I treated the patient in emergent situation. I'm likely to make mistakes. No medical treatment is risk-free. Things have gone wrong does not mean negligence. It was a complicated case. Then I was morally correct. I did not violate any of the ethics. I have not violated any of the MCI professional misconduct. My autonomy was at stake. As a junior, you cannot say that I am not autonomic, I am not supposed to treat patient. I will legally correct. I did not violate any laws. It is not a case of gross mistake or never event. Therefore, I should be given the benefit of doubt. And if you take action against me in such a situations, all my juniors and all my colleagues will afraid to take such cases. And they will not be, that is not going to do justice to the patient. Therefore, my Lord, I plead not guilty. Thank you.
Thank you.
We can deliberate on the issue a little later. I think we're running short of time, so we can talk it over. Great talk, Dr. KK, an excellent presentation. May I now request Dr. Nolan from UK. He'll be talking about how to be safe yourself. We have been talking all the time about how to improve the safety of the patients.
Okay, can I have the slides up, please? So it's my job to talk briefly about radiation protection for interventional cardiologists. It's a very important topic for all of those of us who work in the cath lab. So the cardiac cath lab is the most radiation-intense environment in the medical world. Here are some patient doses for simple procedures and their background dosage equivalent. So a complex angioplasty can give you 25 millisieverts. Your patient can receive 25 millisieverts. And that's the same as 10 years background radiation. What you need to remember is that there is a close linear relationship between patient dose and operator dose. So the more the patient gets, the more you will get. So you are exposed to a lot of radiation when you go in the cath lab. Now these are the hands of one of the early radiation workers who died shortly after this picture was taken. You might think that's a thing of the past, but unfortunately not. This is a case report from 2018 of an orthopedic surgeon who worked with screening in setting bones. Wasn't very careful with radiation protection, ended up with hands that looked like this. Radiation injuries, lost digits. I mean, the long-term prognosis from that's very poor. If you look at your legs, many interventional cardiologists have hairless legs, particularly their left leg. These are some operators from the UK, a case report in the BMJ. This is a study that looks at the eyes of interventional cardiologists and cath lab nurses. 50% of them have posterior capsular lens injuries, early cataract formation, which is a specific radiation-induced injury. So there's an epidemic of eye problems on the way for interventional cardiologists. This is a recent study that looks at markers of DNA damage in people who work in the cath lab. So if you look at the non-exposed individuals, the gray bars, and compare them to the low exposure and the high exposures exposed workers in the cath lab, you can see clear evidence of radiation-induced DNA damage. That, of course, leads to episodes like this, brain tumors, left-sided usually in interventional cardiologists, and the risk of brain cancer mortality for radiation medical workers is 2.5 times higher than for the general population. Now, some operators are good at radiation protection and some are not. So this is data from the RAD matrix study, and at the top of the slide are the operators who generate small amounts of radiation, and at the bottom are the operators who, for the same procedures, generate 5 or 6 times more radiation exposure. So it's your own responsibility to familiarize yourself with ways of protecting yourself. Be an operator at the top of this chart, not an operator at the bottom. How can you reduce your radiation exposure? This is how they used to do it 100 years ago. I don't think many of us were going into the cath lab dressed like that. The first thing you can do is choose your X-ray equipment wisely. This is again data from RAD Matrix, and it shows that for the same procedures, the Philips system produces about half the amount of radiation that the Siemens system does. And there are other similar independently collected information that shows that some systems are superior. And we have had 4 Siemens cath labs, and we will shortly have 4 Philips labs, and this is the major driver for that decision. Patient characteristics are important. Here's a patient undergoing cardiac catheterization with a very high BMI. And if you look on the top, you can see how patients' radiation exposure increases with BMI. But if you look at the bottom, the operator radiation exposure in relation to patient BMI, the trend is even more clear. So as patient BMI rises, your personal operator exposure will increase significantly. Obviously, how long you keep your foot on the pedal is important. So on the bottom is total duration of fluoroscopy on the left, and cine acquisition runs on the right, compared to related to radiation exposure. So the more you screen, the more you acquire, the more radiation exposure you get. It's not a video game. There is a small toxic emitter of radiation that's producing those pictures for you. Remember that acquisition mode produces 10 times the radiation exposure that screening does, so use stored fluoroscopy when you can. Try not to acquire too many images. Be mindful of the radiographic projection that you're using. So you can see here scatter level radiation doses for a PA at the top of the chart compared to a lateral and an LAO at the bottom of the chart. The doses for lateral projections and for LAO, particularly LAO cranial, are much higher. Whenever the tube is close to you, the operator, your dose will be high. So try to use the REO projections where possible. I try to use REO cranial to navigate wires down the LAD rather than the LAO cranial because you get a lot less radiation. Fluoroscopy frame rate is important, as illustrated in this study. So 15 frames per second are the red bars, 7.5 frames per second are the blue bars, and on the left is patient dose, and on the right is operator dose. So if you use a high frame rate, you can turn it down tomorrow and drop your dose by 20 to 30%. In our cath lab, when I saw this data, I asked the radiographers to turn it down to 7.5. None of the operators noticed. Doesn't affect the image quality to any significant extent, and you can turn it up when you need to. If you're a radial operator, the positioning of the arm is important. So here we have thorax, wrist, and eye doses. The red bars indicate the doses received when the patient's arm is abducted, and the second bars indicate the operator dose when the arm is close to the side. So you can see that putting the arm in close to the side significantly reduces dose. And the reason for that is that the further you stand away from the table, the inverse square law dramatically reduces your dose. And when you have the arm in by the side, you can stand further away. Don't use the magnified imaging when you can avoid it. It will significantly increase your dose, as you can see here. Try to cone in as much as possible. So if you cone in by 50%, you will half your dose. If you look at the scatter charts by the patient's hand, where we stand, you will go from the 2 millirem dose to 1 millirem by cones. Keep the image intensifier close to the patient. On the left, there's a 30 centimeter gap between the table and the intensifier, and on the right, a 60 centimeter gap, and those extra 30 centimeters produce a 62% increase in radiation. So make sure that the intensifier is close to the table. Transradial protection boards are useful. We use a variation of this in our lab. Here's the data. Around about a 20 to 30% reduction in scatter exposure to the operator from using an upward projecting radiation protection board. RAD pads can be useful. If you look at this data, again, there's a significant reduction in radiation for RAD pads. We don't use RAD pads, we use a variation of this, abdominopelvic shielding. You can use the bottom half of a lead apron, and if you do that, because the radiation that hits you as the operator is coming out of the patient, not the tube, it's scatter radiation, you will significantly reduce your exposure. Radiation protection glasses are useful. So here is the risk of developing cataracts. On the left is people who don't wear glasses, and on the right is people who do wear radiation protection glasses. If you haven't got them, buy them. Some people like these radiation protection caps. They think it reduces the exposure of their brain. Unfortunately, your brain is irradiated from below. It's scatter radiation coming upwards, and the caps only protect the sides of your head. And in this study, there was only a 3.3% reduction in radiation exposure with the caps. They're pretty useless. Legs are exposed to higher doses than the upper part of the body because most of the radiation comes out under the table. This is a study of the utility of leg shields. On the left is markers of DNA damage before and after entry into the cath lab without the leg shields, and you can see that the DNA damage is eradicated by wearing leg shields. If you don't wear them, well, that's your choice, but it's not a good choice. LED screens can make a big difference. That's not going to play. The over-table LED shield, so people sometimes ask me whether you should have it close to you or push it close to the patient, and here is the answer. So you can see that the lowest dose was from having the shield close to you. It's you that you're trying to protect, not the patient. Have the shield close to you, you will get the lowest dose by that maneuver. There are different types of shields. So we had a shield like the one on the left. We're going to a shield like the one on the right with the downward projecting screens, and this is the data that supports that. If you don't have the LED screen, the LED screen at the bottom, you will get scatter coming through the gap, and you can see that with the combined LED shield, you get a significant reduction in dose. You can drape the bottom half of a lead apron over your under-table shields. This is the Extra-Rad study published recently, and you can see that both pelvic and thoracic doses are reduced, particularly pelvic doses, just by the simple expedient of using the bottom half of a lead apron draped over the under-table shield. So, radiation in a cath lab is an important potential hazard. Many people have died in the past because they work with radiation. Cath lab workers often died from it, and you're at risk when you go into the cath lab. You need to get the best possible kit, and you need to look at the data about which systems emit the lowest radiation. Be aware of the patients who are high risk for radiation, and that is particularly people with a high BMI, but of course long procedures, CTOs, whatever generates lots of radiation exposure to the patient will generate a lot of radiation exposure to you. You need to use the optimal equipment configuration. You need to cone in, get the frame rate down, and use the projections that generate the lowest radiation, which are usually the right-sided projections, and stand as far away as possible. And get the best possible personal protection. That means leg shields and lead protection glasses. Optimize your use of the ceiling-mounted shields. I sometimes see people push it out the way. You want it close to you, pushed down onto the table, onto the patient with a downward lead shield at the bottom. And use the best possible additional shielding. For us, that's a specific radial kit and abdo-pelvic shielding with the bottom half of the lead apron. Thank you.
Thank you, James. Any comments? Any comments from the other side? If there are no comments, let's give a big hand to all the speakers for the wonderful job. Thank you very much. Thanks.
Thank you, moderators and chairpersons, for this wonderful session. Now our next session is Vascular Disease Conclave, and I would like to invite our chairpersons, Dr. George Joseph, Dr. Sanjay Tyagi, Dr. Srinivas, Dr. Sridhar, Dr. Varinder Bedi, Dr. Rajiv Parak, Dr. Prakash Chandwani, Dr. Priya Jagya, and I would also request our moderators to take their seats. Thank you.
Good morning. Now it's good afternoon. We start with two live cases, two. And the first one is from Narayana Institute of Cardiac Sciences, Bangalore. Are we ready to go live for the first case? Anybody from the organizers can tell us whether it's okay.
What about Apollo is ready, New Delhi? If Apollo is ready, New Delhi, Apollo, they can present. Okay, they are there, I think. Okay.
So I think we have
Dr. Bedi, you can join.
On online now. Sanjay, can you hear us?
We can very well hear you. Is it Dr. George Joseph?
Yes, Sanjay. Good morning.
Good morning,
afternoon.
Yeah, good afternoon, Sanjay. Dr. Srinivas here.
Good afternoon, George. Good afternoon.
We have
I'll go ahead, George. This is a live case. I will introduce my colleagues here. To my right is Dr. Gigi Shetty, who has become my partner in doing a lot of things which we do as a structural heart. To my left is Abhishek, our senior interventional fellow. To our right is Dr. Pritesh and Sister Savita, which have been helping us in doing all structural heart. We are from the hybrid lab. So I will introduce the case. This is a gentleman who's 58 years of age, who had a type B aortic dissection. George, you can hear us?
Yes, very well. Go ahead.
Yeah, come back again. Okay. So this is a 52-year-old gentleman who comes from Mysore. He had a type B aortic dissection, which was in 2015. And at that moment, he had some kind of a pleural effusion and a continued backache. So we did a stent graft to seal his proximal entry tear. He was doing very well, but in the last 1 year, his lower end of the aneurysm at the level of the lower end of the stent graft started enlarging. And we noticed, if you can show that CT picture, can you turn that picture please here? Just turn it, then show the monitor. Just show this picture, the CT here. Can you show that CT?
We can see.
Can you see that CT, George?
Yeah,
yes, very well.
So there is a kind of a secular bulge which has appeared at the lower end of the stent graft. Maybe it was a trauma to the intimal flap. And the size of the aneurysm at that level is almost 9 centimeter. We lost connection.
We are listening. We are listening. We are with you.
Can you hear us?
Yes,
very loud.
Go ahead.
Hello?
Yeah, we can hear you, Sanjay.
Yes, darling.
We are hearing you. It's loud and clear.
Right.
Transmission people, they are unable to hear us.
While they're organizing that, this is a classic sign, SINE, that is stent-induced new entry. That's the term for this phenomenon.
They must be calling from here, both ends.
And the usual cause of this is oversizing of the endograft at the lower end. And that chronically pushes out onto the intimal flap, and then at some stage the intimal flap tears, and a new entry forms there, and that becomes aneurysmal.
Okay.
So just give me a, Pritesh, you are here? come this
So,
side.
what is the strategy to treat this, Dr. John?
The strategy to treat is to put in another stent graft and
exclude
make sure that it's a tapered one, so that
Okay.
it
You match
overlaps
the size.
correctly on top, but ends as small as possible lower down.
Can I have a bit of a local, please? He's having some pain.
If I can add on to that also. Okay. If I can add on to that, probably sizing of the endograft is very important at the first stage. So normally for type B aortic dissections, I think we would take about 10% or maximum 15%.
Can I have a
as compared
dilator,
to
please?
aortic aneurysms.
Dilator.
Whereas when you have oversizing, then in that case the chance
Dr.
of
Bedi, I hear you. Can you hear me?
Yeah, we can hear you. Sanjay, yeah.
Sanjay, we've been hearing you all through. It's just that.
Dr. Sanjay, what was the stent graft used initially
All
in
right.
2015?
Leave it. So it was a 38 tapering to 34 first time. I'm going to do this procedure completely percutaneous, which is what we do for most of our patients, put the ProGlide in. So we are going to put the ProGlide, and I usually have been trying to do only 2 ProGlides now, advanced. And most of the time 2 ProGlides are working. So I'm just trying to position the first ProGlide here. Leave it. Just show it here, please.
So what clock positions would you choose when you use 2?
I will choose a 10 and a 2 here. Can I see it now, please? Show me the grinder. That is fine. Out, please. Out. There's a lot of tortuosity, George. So that's my first ProGlide going in, which is deployed. You just pull it out and pull these 2 wires and put some rubber shots here. You can do it later, Gigi. Can I have the wire again? And after this, I'll need a long wire. So you change this to the second ProGlide. I'm going to put a 1 at 10 and 1 at 2. So keep pressing. Don't lose the wire. It's very important that we don't lose the wire at this time, because if you lose the wire, your ProGlide is wasted. And you have to do the puncture again.
Could you tell us what graft you're going to choose to treat this, and what size?
So, this was a tapering graft, George, and I think we have decided to put a 38 tapering to 34. They did not have a 36 tapering. So my concern is that, leave it, not bleed now. Long way. So I'm going to put a 38 tapering to 34. The lower part of the aorta is actually, so that's the flow. Can you show it here, please? Here. Light on, please. Show that light on. I'm blocking this now. So that got deployed. So Gigi, hold this. I need a long wire now. So I will be putting a 10 French sheath after this, sister. I don't have light. You don't have light, Raju, on the...
So that's an important point. After you put in the ProGlides, if you put back the original, say, 7 French sheath, you'll see some oozing. So you need to put in a bigger sheath. So like Sanjay is doing, put in a 10 French short sheath so that you don't have oozing from that same
George, thank you very much for that, because that's important. Put the 10 French sheath. This patient has got 135 kg and his tissues are very deep. I'm a bit worried about that I may not reach the groin and arterial level, so I'm putting a sheath almost in. So now I'll be changing it to a pigtail catheter. Please pass a pigtail over this, flush.
In fact, I was just in Germany a couple of days back.
It is not very difficult to do these things now because we can finish it in about half an hour time.
And I found it's a little.
I will now get an access into the true lumen, which I know.
A small cut into the femoral artery about that, and then with percutaneous, they put your finger on the femoral artery, they puncture it, and then exactly do the same thing, but with a much bigger, of course, device, but it's much more robust. Because you just need to put in one ProStar, but except the cost, of course, is pretty high of that one. It's about $1,000. But ProStar XL is which is, I found it to be very useful.
Dr. Bedi is talking about another device called the ProStar XL, which is basically has four needles.
In fact, you've got four
And
needles inside it.
basically two sutures which are deployed simultaneously.
Gone.
So I don't
So
personally
now I've
like
got
it very
access
much.
to my
It's a
true
big
lumen.
learning
I'm gonna
curve.
put a
And I had some
Lundakus.
problems with it. I find the putting two independent ones easier.
No, but that's, I found
Right,
what the
guys,
trick
please.
was that of making a small nick out there and with the finger just dissecting and going on to the
Lundakus
artery.
wire now?
So even if they have multiple exchanges, you don't have any bleeding.
What's
because every time
what's
you
the house's choice? I actually have not used the ProGlide as yet.
ProStar,
But
you mean?
my feeling, I've become good in doing the ProGlides.
Yeah.
ProStar, I mean, yes. I feel that what you're more comfortable, you should do, and I'm very
Exactly.
confident. And I have started using a single ProGlide in doing TAVRs now. So
Absolutely,
this is
Sanjay.
quite-
I think
okay, let me prepare the graph now.
You should use what you're comfortable with.
Which is the
and-
wire which you've
All
used
of
for
us are.
backup wire?
Yeah, just keep
Dr.
showing.
Sanjay,
Can I have the device?
have you
I think
taken
you're not
backup
ready with
wire
the device. Yeah.
or Amplat Super Stiff? Which wire?
This
have
is
you
a
taken?
Lundakus right now.
Okay,
This is a
Lundakus.
Lundakus.
So I think right now you only have.
Sanjay, what is the diameter of the aorta below this aneurysm, the true lumen? Do you have
So I know you're going to ask the judge that question because you see there is another aneurysm forming at the level of the splanchnic vessels. The maximum dia of that is around 5 centimeters right now, and I think very soon that will probably also enlarge. The diameter of the aorta in between the splanchnic vessels in the previous graph, just below the true lumen diameter is 34 by 14.
Does that
So,
include the false lumen also? Or
Can you show it here, please?
is it true?
No, the false lumen including is almost like 8 centimeter. So we should have taken this.
No,
graph.
if
So
the
I'm just
graph-
preparing the graph here. I'll show it. Flush it, please. Yeah, George, go ahead.
Yes, the graph that's already deployed, you said is a 38, 34. So assuming that it has reached 34
Correct.
at the lower end, the aorta below the new aneurysm that has formed looks almost just half that size.
Exactly.
So it's probably just a 20.
Yes. So it measured 34 in one direction. It's a kind of a oblique lumen. It's measuring 34 and about 16 in one direction. So I'm not very happy to sort of deploy a very large device, and that's why I have taken a tapering device again. I'm using a 38 tapering to 34. Of course, my concern is he's a very, very big man. His aorta diameter at the top is quite big. So we'll be changing now, Gigi. So you're okay? Just leave it there.
And you're putting in a 150 device, Sanjay?
On this side. Come here. Can you?
It's a 150 or a 100?
It's a 167,
150,
yes.
Yeah.
It's 167.
Yeah.
I would actually argue for more
What
taper.
would you do, George? Would you put a smaller one?
Yes, I would put a
I know,
device
but
that's
you know-
tapered by 10 millimeters. Now, there is a Cook TX2 device which is tapers 10. So they have a 38-28 or a 40-30. So that would overlap correctly on top and then end
Can you
much
show it
smaller
here?
at the lower end. Because you want to prevent this same problem occurring at a lower level. Absolutely. So that is...
One more complication. Yeah, agree with you. So that's now I'm inserting this device. So you just follow this, please. Show me the groin now. Show me the groin. Follow.
So
It's
what's
very
your
important, and keep the wire
what's your
fixed there.
distal?
Keep the wire fixed there.
So what's your distal endpoint for the device going to be, Sanjay? How lower down are you going to be coming down?
I think I will end it somewhere around T. I will come around somewhere around T11 or T10. Okay, we'll take a shot here, please. Pigtail.
And
You ready?
any spinal cord perfusion techniques or anything that you're looking at in terms of any post-op paraplegia or
He's been a
something, any
chronic dissection.
prevention?
I'm not going to land below T11. Suck, please. Suck, please. Suck, please. Suck, please. Just give me a DSA only, just 20 ml contrast.
Dr. Sanjay, did you
Unlock
cover
the
the left
table.
subclavian artery when you did
Wire,
the stent
please,
graft
wire.
in 2015?
I didn't cover it.
You didn't cover it. Yeah,
So
that's-
probably yes,
Okay,
we
let's
can
take
get
a shot
away
there.
without doing the CSF drainage.
No, I need to see some more. I need to see more. Unlock the table, please. Raju, you please concentrate here and don't think about anything else right now. Injector. Tell me when you're ready. I may have to push in a bit more. I want to see a bit more of aorta down. Bit more of aorta down. Stay there. And no zoom now. Reduce the zooms. No zoom?
He's going to do an angiogram.
Okay, you ready? You ready to inject?
It's all on one side.
Inject.
It's not centered.
So the celiac arteries are actually about 2 frames down, so I'm just going to go a bit more up. Okay, can you mark the celiac artery on the monitor, please, and don't move the table now. Okay, one more time. Okay, mark this. I want one more injection after this. So mark the celiac artery, run the last shot. Stop. Mark the celiac artery. The celiac artery just below, it's below there. Here, mark it there. So I'm going to go somewhere around, I would say, T10 position. And I will do a bit more cover up, so I have to
Yes,
go a bit
way
more
down.
up, and I want one more shot after this to confirm my
See the
position.
splenic.
Okay.
I
Okay.
think
Can I
you're-
see the top end again now? You wipe that. Sure. George, what do you think?
Yeah, you've got more than adequate overlap. You can see the marker, the mid marker of the
Yes,
thing,
yeah.
that has already crossed the lower end of the first endograft. So you're good to deploy.
Yeah.
What you need is 5
Okay,
centimeters minimum.
let's take one more shot to see the celiac here. Please, Ramatullah, please hold your breath for a second. सांस रोक लीजिए अपना, रोक के रखिए. Inject. So the celiac is much lower. Are we okay here?
Yes, everything's good.
Yeah.
So I'm going to deploy now. So I'm just slowly opening the device.
4 mm taper. Again a big one.
So what I do is, George, that I tend to sort of do it very rapidly once I deploy the top end, because there is nothing to think about here. I just deploy the device, and that's it. So that's it. Did you see that deployment?
Yes, we did.
Yeah.
So now we're going to release the top cap.
Top cap, yeah.
There it
I have released the top cap and captured it. Gigi, can you feed that, Gigi? Wire. Okay. So can I have the wire? Just remove the device and show me here.
So
No,
when
wait there. Let's take a shot first. Let's take a shot. Can I? No. Can I remove the pigtail from that side? It's jailed.
So when you remove the delivery system, what sheath are you going to put in?
I'm going to just close it now. I'm not going to put any sheet.
Oh, okay. You're just winding up with this. Okay. I usually put in an
Thought
18
I'd
French
finish it.
sheath.
Can I see? Oh, okay. Show me down. Let's see where my pigtail is. I can't see much here. That's going. Okay, follow this. Hold the wire, Gigi. Can you hold the wire?
I think
I'll do a digital.
but
Okay,
this is
follow,
a
please.
morbidly obese patient, so you can see the
Yeah.
fluoroscopy is compromised, and you've got
Difficulty in advancing thing. Can I have an Amplatzer wire here, please? Quickly.
He's almost got about
Because it's very
three
difficult to
struts
push
sealed.
these things. I have to show you the pigtail injection, and I want to show you the closure. Do I have time?
Yeah, I think we're still good.
So George, what I did, I just put a stronger wire, which is easy to push. Hold the wire, please. Okay, that's it. We're ready to inject now.
So I need some injector. What's the pressure of the patient? It's pretty good, 130. Injector. Okay, connect. Suck. So this one I want digital, and give me some 20 ml only. Suck please, suck. That's good. Okay, unlock the table. One more zoom. So I'll be doing 2 injections, Raju. Okay, I want to see the covered part of the stent graft. You ready? Oh, this is okay. Oh, this has come back a bit. Anyway, I'll inject that. You ready? रहमतुल्लाह साहब थोड़ा सांस रोकिए, रोक के रखिए. Inject. Okay, that looks good to me. One more shot to see the celiac vessels.
So the aneurysm
move the
is
table up.
looks good. Completely excluded.
Sealed, yeah. Go ahead. One more time. फिर से सांस ले लीजिए, sorry. एक बार फिर से सांस रोकिए. Inject. I think this. So you saw there is a leak into the false lumen, George, and I think he may require another procedure down 3 to 4 years, 5 years to look at his splanchnic vessel, but I think I'm done. So I'm going to pull this out. The aneurysm is sealed, and Gigi can take the device. So you have to show here. I want to press. I'm taking it out. Pritesh, come this side. Pritesh is more experienced. I'll take him. Wait, Gigi.
Oh yeah.
Light on, please. Light. Gigi, just 1 second.
So Sanjay, did you use ultrasound to get your femoral access initially? Or did you just go by palpation?
No, I didn't. But table down, please. Can I have the... No, I don't go by palpation. I always put a pigtail from the other side. But I've been trying to use ultrasound, George, and it requires a bit of learning curve. I use for TAVR now that, and but it is a good thing to do. But I always check, and for TAVR, if I have a worry, I put a protection band. Leave it. It's not bleeding. It's not going to bleed.
So you had a pigtail coming over from the left femoral, and then you punctured into the middle of the
I
pigtail.
always do it. I always pigtail. Yeah. Especially for
very, very important to get a anterior puncture over the femoral head. At least a little bit above the femoral bifurcation.
Leave it.
And one way of doing it is the way
So
Sanjay
this
is
looks
done.
okay. Can you show it here?
So he's tying off the proglide sutures.
See, that looks good.
Yeah, that looks good.
He's
Just wait, stop, please.
no bleed there. So this was
I just put 2, George, and it's working.
yes, that's 2 is enough, but the problem is sometimes one breaks, and then you're in trouble. So it's always
that's a problem. I agree with you.
So
Okay, so I do a pigtail injection now, the other side, just to see what I'm...
The only thing is to compress as hell.
Where is my pigtail?
And the subcutaneous tract should be properly dilated so that the suture reaches the vessel wall.
Okay,
Which I have
yeah,
not
that I
prepared
did.
well.
That
Then
I
the
did.
suture may not
Okay,
reach the
injectable.
vessel wall. That's another important point.
Yes, it is. I totally agree with you. Okay, flush, please.
Yeah.
Okay, this should be a cine. Suck, please. This should be a cine. I want to follow it up to see the lower part. And if you want to move the camera that side, please do it, Raju. Quickly, because... No, fine.
Sanjay, we have only about 2 minutes.
Move the machine that side. Now I'm going to show you just quickly. Come on, Raju. We have only 2 minutes, so you have to do it fast. Last injection. This will be a last injection.
Anyhow, in case we go
Yeah,
off the air,
okay, ready?
that was a very well demonstrated repair of a
Okay, let's do it, please.
sign.
Inject. You ready to inject? Raju, you have to do it quickly. Come on. You ready? Okay, let's go. Inject, table and lock. Follow it.
Yeah, it's fine.
That looks good.
It's fine. It looks good. Yeah.
Okay, I'm going to remove the wire. Show it here. table out, 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 table out. So I'm going to just pull this wire out. I have not tightened very much because sometimes the wire gets caught. This looks fine, and that was at 24 French. This looks fine, George.
Yeah, it is.
Okay, there's
You
a
show that?
question. Yeah, I think you've got some.
Yes.
The iliac is a bit, that's accordining. I think
yeah,
if you pull out the wire, that will.
This coordinating, you want me to do one more shot? I can do one.
No, not necessary.
I think it looks
Let's
good.
record
It looks
I can do
good.
one more shot.
It's good.
Yeah, it looks good. It looks good. Yeah.
Looks good.
Yeah.
Sanjay,
Okay. So, any questions, George, and what do you think? Your comments?
There's a question from the audience. What happens to the artery of Adam Kivix? Needn't we profile it before the deployment? Do you want to take that, Sanjay?
No, I don't think so. I usually, no, I don't. I can hear the question, but then we usually don't worry about it. And this is a chronic dissection. I'm sure that he has multiple collaterals. Such patients never develop, paraparesis. I have never had a paraparalysis so far. I may have done nearing 500 cases, but all of them are not dissection, but mostly dissection. I had one patient who had a paraparesis which responded to CSF drainage. So if it is required, we are ready to do a CSF drainage, and I have stayed somewhere around T10, 11. Artery of Adamkowicz can be there, anything from T10 to L3, but the most common site is anything from T12 to L2. And we usually don't worry about it, especially when your left subclavian is intact. So I think as far as that is concerned, I never worry about. रहीमतुल्लाह साहब अपना पैर जरा हिलाएंगे दोनों बहुत बढ़िया बहुत अच्छे तो and I do all these cases, George, including my TAVRs now completely, no anesthesia at all, no sedation at all, because that's the best way to do it. Because when you make the patient unconscious, the swings in hypotension are very, very high. And patients who are awake actually respond much, much better. So I think all those people who are doing TAVRs also doing all this should stop using any kind of sedation, just the local, and that works the best.
Yeah, have you kept the mean arterial pressure up deliberately during this case, or you're not concerned too much about that?
No, I didn't actually. I didn't do anything. His pressure right now is 130/85, and at the beginning of the procedure it was 180. So I was a bit worried that his pressure may go up. So I kept the pacing wire ready to pace in case the pressure was very high. But I'm in the mid-thoracic aorta. It's more, of a concern when you're doing the proximal aortic deployment, where
Sanjay,
possibility of windsock and movement of the graft.
We're going to lose you any moment now. So thank you very much for a great demonstration.
Okay, thank you very much.
Thank you, Sanjay. Thank you,
much.
Gigi.
Well done.
Well done.
Thank
Please
you.
give them a
Thank you. Thank you, Gigi. Thank you. Thank you. All the best. Thank you. Thank you.
I mean, there's another case. 1 o'clock. Another case for half an hour.
We have a live case from Italy now.
Hello, good morning, India Live from Novara, Italy, and we are here to show you a case of erectile dysfunction that we currently treat in our hospital almost every day. With me there is Dr. Riccardo Iorio, who is a friend and a co-worker, and here in Italy it's Sunday morning, and so I really wish to thank all the cath lab staff and nurses that have been so patient to come on Sunday to work with you guys and India Lives. Okay, if we can start the slides, we will show you the clinical history. Guido, thanks a lot. Okay, prossima. Yeah, you know, I mean, in India we thought, you know, we can joke about this type of pathology, but you have to keep in mind that, you know, more than 3 millions in Italy and 300 millions in the world are affected by this pathology. Guido, prossima. This is a young man, as you can see, with no cardiovascular risk factors except for smoking, but he withdrew smoking approximately 15 years ago. He had only positive clinical history for a saphenectomy that was done in the left leg in 2016. And he started to complain about erectile dysfunction 4 years ago. Of course, as a natural history of this disease, the patient usually start to have some problems. He goes to urologist, and then the urologist send the patient to cardiologist to see if they can give PDA5 inhibitors to improve the erectile dysfunction symptoms. Having said that, he was seen by a neurologist, if I can have the slide back, 3 times, and then referred to me. The urologist performed, as usual, dynamic Doppler. Can we have this, the other slide, Guido? Next. You see, the patient performed in 2016, 2019, and 2020 dynamic penile Doppler, which is usually done by catheter injection, usually 10 or 20 milligrams. And you see that the systolic peak velocity in this young guy on the right pudendal artery, it's 19 centimeter per second with a resistant index of less than 0.7, and the left pudendal 20 centimeter per second with a resistant index again of less than 0.7. Of course, the urologists have suspected fibrosis of the corpora cavernosa at the Doppler examination. What I can tell you from my standpoint is that there is some hemodynamic compromise, but it not seems to be so severe. We interrogated the patient. There is a questionnaire which is called IEF, International Index of Erectile Function score, that goes from 0 to 15. We give 5 questions usually to the patients, and of course 0 to 5 is a severe, 5 to 10 it's moderate, and 10 to 15 it's light erectile dysfunction. The patient has as a score 5. So clinically speaking, he has a severe erectile dysfunction which does not respond anymore to phosphodiesterases inhibitors. He's on tadalafil with no response for more than 1 year. Can I have again the slides? So what we did, due to the fact that the patient arrived for this live case on Friday, we did an hormonal laboratory test analysis, and you can clearly see that, you know, all the hormones are quite normal. He has 6.2 LH, the free testosterone is 10.3, it's slightly increased compared to normal. The free sex hormone binding protein is 60, which is again slightly increased compared to the normal, but nothing really that we can justify this severe IF. Possiamo andare avanti con la prossima diapositiva. Of course, what you can do in the screening of these patients is to do a CT scan angiography. And you can clearly see the right pudendal artery. This was done yesterday afternoon. The right pudendal artery and the left pudendal artery looks quite normal. This is a voxel gradient reconstruction on the right panel. So basically, of course, due to the fact that the case was not organized, this is true word. Next slide. Guido, prossima diapositiva. As you know, there are several zones where you can identify atherosclerotic disease in a CT scan. Usually, the atherosclerotic disease, in the majority of cases, is localized in zone 4B, 5A, and 5B. So, mid part of the internal pudendal artery and distal part as a zone 5A and zone 5B. So as a common penile artery and dorsalis spinis. Prossima diapositiva, Guido, grazie. So basically, the idea is as a first-line treatment in this type of patient, when you have an IF score which should be less than 15 points, penile Doppler which is positive, as in this case, and of course, positive penile angio CT. If the patient does not respond to PDE5 inhibitors, then second-line therapy for atherosclerosis is to do plain balloon angioplasty followed by drug-eluting balloon treatment of the pudendal artery. Then, of course, there is also a venous part, which it's also important due to the fact that you have to think about a car tire. If you have a leak in the tire, you can put as many airs that you want, but the tire will not inflate. So also the venous parts needs to be good. But in this case, it doesn't seem that he has venous leakage due to the fact that the index resistance is 0.7, normal it's 0.8. So, of course, for demonstration, we will perform with you a diagnostic evaluation. We know for sure that the artery are not diseased, but what is important that I would like to show you the projection that you have to utilize in order to evaluate these patients. The diagnostic part is quite complex due to the anatomical variables and the problems that you can encounter in selecting the pudendal arteries. And last but not least, we will give you a glimpse on CO2 angiography, which we utilize every day to evaluate the fibrosis of the corpora cavernosa, due to the fact that CO2 diffusion is much, much higher compared to contrast media. And so you will rarely see corpora cavernosa during contrast injection. You can clearly see corpora cavernosa with CO2. And of course, if you don't see the corpora cavernosa with CO2 injection, you will immediately think that there is a problem at the level of the corpora cavernosa, such as microcirculation disturbance and, of course, fibrosis of the corpora cavernosa itself. Now, if Vincenzo can show, yes, do you have questions?
Yeah, no, I just wanted to remind you that we have only 30 minutes and we already finished 12 of them.
Yeah.
So,
Yeah. We will move to the diagnostic part that we have done on the left pudendal artery. If I can have the registration that we have done, of course, we start with a normal angiography of the carrefour. You can clearly see the two hypogastric arteries here that are normal. Then we move in crossover and we check with different oblique projections the origin of the hypogastric arteries. Of course, now we are selectively engaged here in the hypogastric space, and we are moving to the diagnostic projection. You can clearly see the pudendal artery is the artery that runs on the right side of the screen and then makes a small curvature going in the middle part of the patient. If I can have the next slides with other projections, you will see that moving from oblique projection caudal, which is this one, and you can clearly see the pudendal artery on the... Can I go back, Vincenzo, 1 second, so I can show, okay. Again, this is the pudendal, it's the artery that crosses the screen and that distribute in the middle of the screen itself. You have the common penile artery as a last part, and in the dorsal penile artery that you slightly see going in the mid part of the screen. Now I want to show you the CO2 angiography, which is again this frame that we currently do. As you see, the distribution of the gas is... Can we go to the next slide so we can show the India Life friends the complete angiography? You can clearly see, first of all, with one angio, you have also the left pudendal artery that you clearly see on the left with the distribution. But if we keep the CO2, we will see the distribution on the cavernous body. Here in the last frames, you can clearly see a small distribution of the CO2 on the cavernous body. I'm telling you that this is not a normal distribution, due to the fact that when you do have a normal distribution, you have an explosion of CO2 within the corpora cavernosus. Now we will perform the contralateral injection just to evaluate also the cavernous body. We are utilizing a left mammary artery in order to selectively engage the contralateral artery. This is the left mammary artery, and of course we were going to move on the contralateral side to evaluate where the origin of the hypogastric artery is. We are on the iliac. Riccardo, can you inject 1 second? Can we increase a little bit more, Lorenzo? Mi metti 5 per favore. We are, for selective injection, we usually give 3 cc's, while for iliac we move up to 5 or 7 injection. Okay, here is the hypogastric artery that we selectively engage. Can you check? Okay, we are at the origin. Now we move with a Terumo wire, of course, to engage more deep the artery, and then perform with you a diagnostic angiography. As I told you, the most difficult part, especially at the beginning, is to understand who is who, because there are several arteries originating from the hypogastric, which are mainly the gluteal arteries, inferior and superior, or internal or external, as you wish. We are probably here in a gluteal. There are branches for bladder, there are branches for obturatory vessel. We are, with the push and pull technique, moving inside the gluteal artery, and usually we start from there the diagnostic part. So we have utilized the contralateral view. Now we move to the homolateral view. We usually start with an AP to understand where the pudendal artery is, Lorenzo 5-5, and as you will see, the pudendal artery runs around the bladder, okay? Here it is, it's the big branch that you see here on the left that makes the curve around the bladder and distribute in the middle part. Then we move usually to the caudal homolateral view, so we are working here on the right, so we move to the caudal right to open a little bit more the artery. Lorenzo, go. And here it is, again, the curve and the distribution very well, you know, that you see in the middle part of the screen. Of course, this patient has nothing that needs to be treated. We will, you know, do also a cranial view in order to better understand, especially in cases of diffuse disease where the stenosis are. And again, here it is. Okay, you see some small branches that distribute for the prostate, which is slightly underneath the bladder, and then at the end you see the pudendal artery with the common and dorsalis penis bifurcation. Now we will do CO2 angiography as promised to evaluate the cavernous health system. We are connecting the system, and here it is. Guido, can I have the slide again 1 second? I want to show you to India Live friends the CO2 angiography. No, go back 1 slide. Okay, you see, manual injection, we at the beginning of our experience, we were doing manual injection, but of course, first of all, it's not safe. We cannot give a consistent pressure, and of course, we have a lot of radiation exposure since we have to be very close to the patient. With automatic injection, there is a machine that is depicted in that slide. You have a very consistent pressure. We inject at 300 dpi and 80 CO2 as a volume. And this makes very reproducible any examination. Now you have to purge the system. Lorenzo, possiamo fare lo spurgo? And we again move in this projection. Okay, vai. Okay, we start the injection, and you will see the CO2 gas moving. Here it is, the pudendal artery. Don't move. Don't move.
We're not seeing the fluoroscopy. Ah, okay. Now we are.
Okay, if you can see it, the pudendal artery appears here on the left and distribute in the middle part. You see a small distribution of CO2, again, due to the fact that the viscosity it's much less. As you have seen, by contrast, you cannot appreciate the cavernous injection. But what is important is that this distribution is not normal at all, due to the fact that we should have seen a complete staining of all the cavernous body for the entire segment, so for the entire organ, genital organ, while we see only, a very small distribution at the base of the penis, but as you see, along the penis, there is no distribution. So we agree with the urologist that probably this is a fibrosis of the corpora cavernosa. This piece of information is quite important due to the fact that the patient does not respond anymore to PDF inhibitors. You have diagnosis, a clear diagnosis of fibrosis. And third, the only solution that we have in this type of patients is to do a penile implantation. Due to the fact that when there is fibrosis of the corpora cavernosa, it's like the microcirculation in myocardial infarction is gone. And of course, you can also expect that the penile implantation could be a more difficult procedure due to the fact that the corpora cavernosa are quite stiff. And so for the urologist to enter with the surgical instrument will be more difficult than with, I would say, healthy corpora cavernosa procedure. Now, having said that, what I would like to show you is, cases that we did this week, just to give you the idea of what we have in case of atherosclerotic disease of the pudendal artery. Vincenzo, may I have the video that we recorded, and as you will see, with Diego, we have also the slide. In case of atherosclerotic disease, what we utilize is, as I told you, drug-eluting balloon. I don't have, here it is, which the only drug-eluting balloon that we are utilizing now in our cath lab is a Magic Touch, which is unique due to the fact that it's a sirolimus delivery, due very nice engineering work has been done. The sirolimus is converted into submicron sized particles with encapsulation of sirolimus in carrier, which is represented by phospholipids. And then this carrier and drugs are transferred into the vessel wall for drug retention. Again, if I can have the other slide. Okay, this is the case that we have treated a couple of days ago. You can clearly see here diffuse disease of the pudendal artery. Here it is. You can clearly see almost 90% stenosis of the pudendal artery, but very long segment. If we go to the next frame, you can see and appreciate a little bit better here in another projection. Next frame. Okay, we are entering with 0.014 wire, avanti, avanti, avanti. Okay, we are selecting with a guiding catheter, avanti. Okay, here it is. You can clearly see the diffuse disease of the pudendal artery district. We are almost at the base of the pain with the tip of the wire, avanti. Of course, in these cases, what we do usually, we treat the most severe segment with a drug-eluting stent. In this case, was a 2.5 stent. And then we move, here it is, and then we move with the drug-eluting balloon after predilatation to treat the other segments, and you can clearly see that above the stent, okay, this is the predilatation, and then we go with the drug-eluting balloon. Prossima diapositiva. Okay, now we're gonna treat the distal part. Again, you can clearly see the disease in the distal segment. Prossima. Prossima. Okay, probably this is the last one that the balloon was not recorded, but this is the result that we get after drug-eluting balloon implantation and the drug-eluting stent treatment of these segments. So what for screening, what is important for you as a key message and take-home message is that the CO2 angiography can be done, of course, in patients with renal insufficiency, but it's not this case. But in the pudendal artery disease, in order to evaluate the response of the cavernous body to CO2 injection. Second, if there are stenosis, atherosclerotic disease, these are usually atherosclerotic plaque, like in the coronary artery. There was a Portuguese study demonstrating that we can have a type 5A and 5B of the American Heart Association study classification, so complex plaque in this disc. And you can treat with second-line therapy with the drug-eluting stent and, of course, drug-eluting balloon. In our case, we utilize a sirolimus coating balloon. I don't know if you have questions from the audience or from the panel.
That case you showed us, you did the right side. Was the left side normal? And would you do bilateral angioplasty anytime?
No, what we usually do, you have to keep in mind that there is also an important psychological component in these patients. And we treat them like, breast cancer. If they have to do a double implantation, they will first do the left breast and then the second breast. And we do the same. So we do a complete diagnostic angiography. Then we treat the most severe side and stenosis. Then we wait 3-4 months, and then we bring the patient back if he still has symptoms, because most of the time the patient responds very well. They withdraw completely the PDE5 inhibitors, and so we wait to treat the second side.
And the antiplatelet therapy for such procedures, would it be similar to coronary procedures?
If we treat the patient only with drug-eluting balloon, we give dual antiplatelet therapy for 3 months, and then on aspirin, it will continue on aspirin. If we have a drug-eluting stent, the size is similar to the coronary, and we give them 6 months dual antiplatelet therapy and then aspirin alone.
That was a fantastic disposition. Just a question, you proceeded with an angiogram and then discovered that this patient had fibrosis of the corpora cavernosa. Is it possible to diagnose that condition prior to doing an angiography? Because after all, it's an invasive procedure. So would a direct injection into the corpora cavernosa showing that this is going to be a fibrotic cavernosa, which means obviously there's going to be no possibility of any intervention. Is that possible?
This is a very good question. We are talking about pioneering applications of CO2 angiography. We are the only center in the world that has started to do CO2 angiography in the pudendal artery district. We never try, honestly speaking, to do a direct cavernous injection. We perform routinely CT scan angiography with cavernosography for venous disease. due to the fact that you have to evaluate the anatomy of the venous plexus in order to do embolization if the patient has prevalently venous disease. We never inject CO2 directly into the cavernous tissue. It's a good idea. We will try during a cavernosography to see what we have. But keep in mind that usually this patient that comes with a positive Doppler, we don't routinely perform CT angiography. I will recommend it to do it at the beginning to get orientation due to the fact that the anatomy is quite complex in several cases. So CT angio will help the operator to get oriented in this difficult anatomy. We bring the patient immediately in the cath lab. It's faster for us to do diagnostic angio, CO2 angio, and if we have a stenosis, we treat them immediately.
Okay, Dr. Giuseppe, thank you so much for that very excellent description of how you evaluate and treat these patients. And most of us are quite unfamiliar in this territory, and you have given us a very lucid and step-by-step introduction to this topic for us. Thank you very much.
You're welcome. Namaste. Namaste.
Namaste. Fantastic. Okay, so that brings us to the end of the live sessions, and we get on and start off with the symposium, Issues in Peripheral Vascular Interventions. So we're going to start off with a presentation from George Joseph, who obviously knows, all of you know him, needs no introduction, my co-chair. He's going to talk about special techniques and technologies for peripheral interventions. George from Vellore.
Good afternoon. In the next 10 minutes, I will cherry pick a few techniques and technologies that we have found have made a big difference to our practice in the last few years. It's impossible to cover everything, so I've just picked out a few which are important. The first is in the area of thoracoabdominal aortic aneurysms, and we've been doing fenestrated repairs, and we have moved on to something called cuffed fenestrations to facilitate this. So here's a very large thoracoabdominal aneurysm which is involving both the common iliac arteries. It's starting in the mid-thoracic level, it's ending at the iliac bifurcation. So the important thing here is we've got to preserve all the branches that take off from the aneurysm and the internal iliacs as well, because that's an important source of spinal cord blood supply. So we make fenestrations in the graft based on the CT anatomy. And we basically had a tubular graft on top with 5 fenestrations. There were 2 right renals, 1 left celiac and SMA. And then we had a bifurcated graft, and then we would extend the bifurcated graft with iliac limbs, which have a single fenestration for the internal iliac artery, which is also cuffed. So altogether 7 fenestrations. So we pre-mark the target arteries using a left axis, which allows you to put multiple 4F catheters through. And then that's the final result of that case. You can see the 5 fenestrations on top, celiac, SMA, and the 3 renals. And then lower down, you have this bifurcated device extended by iliac limbs, which have a single fenestration for the internal iliac artery, you can see in the right panel. And this was in June last year, and in December we had the follow-up CT, which shows that the aneurysm is excluded, and all the 7 fenestration stents are patent. So this is a way of preserving the internal iliac arteries, and these cuffed fenestrations have really made things different. They provide a great seal, and we don't get leaks at these fenestrations, and kind of changed the game in this field. So we moved on to the arch, where we now do total arch repair, and here again we used cuffed fenestrations. So here is a patient who had a type A aortic dissection that started in the ascending aorta. He had surgery in 2015 for that, and the rest of the aorta is still dissected and the false lumen is expanding. Here's the surgical repair. The 2 yellow arrows show the extent of surgical graft.
And then we've got to overlap this graft and then take the repair all the way down to the diaphragm level. And you can see that the aortic arch branches are almost horizontal. They're parallel to the aortic arch. So we had this endograft with 3 fenestrations, and now we have pre-wired these fenestrations. These wires come in through the subclavian fenestration and go back through the innominate or the left carotid, and they will be external at the femoral level. And they are all 3 are cuffed. So to deploy this without rotational error, we have this figure of 8 marker, which you must see on its edge, and then we have another wire from the left carotid down, which tells us the axial orientation. So there are 2 orientations that you have to get right, the rotational and the axial. And so we deployed it, and then we cannulated the 3 fenestrations, put fluency stents into them. Now this patient also had the dissection going up the left subclavian, so we put a plug there, and there was a large false lumen below, so we put a candy plug below. So this is the completion of that case, and this is the follow-up CT. You can see now the entire thoracic aorta is excluded, and the fenestration stents are all patent, and the plugs are working, and the false lumen is solidly thrombosed, as you can see on the right panel. So cuff fenestrations, like I said, improve sealing, and when you pre-cannulate these fenestrations, you can reliably cross them, and we have this rotational and axial orientation system, which gives you very precise deployment, and this whole thing is completely percutaneous, so that reduces the morbidity. Here's a case I did this Wednesday, that's just 5 days back. This is a patient with a type B dissection with a right aortic arch, and there are 4 aortic branches. You can see the 2 carotids take off from the ascending aorta, and then there's the subclavian and which take off from the arch. And in this CT, you can see the ascending and the descending are on the right side of the spine. Usually the descending comes to the left side of the spine, and you can see the huge false lumen wrapping around the true lumen in the descending aorta. And so we made this graft with 4 fenestrations, pre-cannulated them. We cuffed only the subclavian one here because the rest of it is in the seal zone, and resheathed it, and that's the final result. You can see that we've started our repair from the sinotubular junction, just above the left coronary artery, and then taken the repair down to just above the celiac level. So with this system, you're able to, accurately treat the, land the device and get a total arch repair. So the aortic arch today for us is entirely endovascular. I really can't see a situation where we need surgery for that, unless the ascending is diseased and we don't have a landing zone. Now, I'll talk a little bit of access. Access is very important, like we were discussing in Sanjay's case, and we always use ultrasound now to get access, and we also use a needle which is called the EchoTip needle made by Cook, so that you can see it easily under ultrasound, and then we use this micropuncture set to get into the artery. Now, this may be very familiar to some of you, but it makes a huge difference. If you use the regular big needle, you could have this situation where the needle is got a long bevel and you get blood coming out, but actually the bevel is only half into the artery, so the wire may dissect like you see on the right. And we always go percutaneous now, and we use these ProGlide sutures like Sanjay has demonstrated in his case, and we use 3 of them for large bore accesses. We also use the carotid access quite commonly now, and it's always percutaneous. Now this is one situation where you may want to do that, a very diseased arch or a type 3 arch, and we use ultrasound to get into the carotid, and we can put a small sheath in. This is pointing upwards, but we may point it downwards, like in this very ugly aortic aneurysm. We did an endovascular repair, and we put in a fenestrated graft, and this is a carotid stent being deployed from a left carotid 7 French axis. And then after and that's the final picture with the complete repair done and 3 fenestrations. And then we use this angioseal device to close the puncture point in the left common carotid artery. Another axis we are using a lot is the axillary artery, which was traditionally a surgical axis, but for us now it is percutaneous. And this is used, this is an example, a thoracoabdominal aneurysm, basically starting distal to the left subclavian and going all the way to the bifurcation. So this is the most extensive type of thoracoabdominal aneurysm. And we opted to use a technique called the octopus technique here because of its complexity. We basically use a bifurcated graft, and into the short limb we put 3 branches which deal with 3 visceral arteries, and then a 4th branch can be added on as a sandwich. And so that is the repair that we did. On the right you can see there is the bifurcated graft with 3 branches coming off the short limb. And then here you can see the 3 branches, 2 renals and the SMA. I think in this case, we did not save the celiac. There's no celiac to be seen. That was, I think, plugged in this case. Now, to get these 3 branches, you have to simultaneously deploy fluency stents. And so we needed 3 axillary axes, which are taken separately and percutaneously. And then when you finish the case, you'll have 3 long 9 French sheaths in the axillary artery. And then we deploy a fluency stent across all the 3 puncture points over a brachial femoral wire loop, and then simply pull the 3 sheaths out. And then you can immediately do an angiogram with a catheter that's a guiding catheter that's waiting upstream. And then you can, if in case there's a bleed, you can quickly come in with 1 more stent. But in this case, there was no bleed. There was complete hemostasis at the end of the case. Thank you for your attention.
Thank you, George. That was obviously a masterly exposition of all that you can do, and you'll get most of our surgeons out of a job for sure. And you're absolutely right. I think endovascular interventions in the aorta have completely changed the scenario that exists, and more cases, in fact, probably as many as one does, are being done through endovascular interventions. And whatever you've shown are obviously techniques which are, of course, with the master, somebody who used to doing these, of course, that is something which is doable. And they're definitely far cheaper than the elephant trunk and the ordered devices which you can order and probably just use as well. So, any questions?
If I can ask George, the next future that I think what I look at, and you're going to be probably one of the pioneers in doing that, doing a chimney Bentall along with doing the ascending aorta. How do you look at the role of doing because right now you're doing a Bentall for all these ascending aortic lesions where we don't have much of a neck. So how do you look at the role of doing a chimney Bentall along with ascending aorta?
Yeah, very tantalizing subject. The problem is that the most common aortic valve pathology that you see with ascending aortic lesions is regurgitation. We seldom see aortic stenosis and aneurysm in the ascending aorta. That's there, but it's very rare. So we need to improve TAVR techniques for normal to regurgitant aortic valves. When that is more mature, then an endobentall would be really in business.
Yeah.
But right now it's only for stenotic valves, and that's a very rare combination.
I think, but now they had the first-in-man trials right now, and according to that, they've been able to combine it with a TAVR, doing a CHIM, and along with that.
Yes, it's coming. It's a matter of time.
Yeah.
It's all wonderful, Dr. George, the way you have developed the interventions, especially with the simplest of the techniques available on the shelf, and to such a level. And these complex procedures cannot, it makes it so easy, actually, the way it has been done. Thank you.
Thank you.
Dr. Tyagi.
Introduce.
Dr. Tyagi.
Okay, so speaking to Sanjay Tyagi.
Okay. Yeah, I think Dr. Girish from GB Pant is speaking instead of Dr. Tyagi.
Thank you, everyone. Since Professor Tyagi was out of station, he has asked me to present this, his presentation on interventions in aortic arteritis, our problems or solutions. Unlike atherosclerosis, the management of patients with aortic arteritis is difficult because of the reason that diagnosis in early course of disease is very difficult, and there is lack of standard and reliable parameters for diagnosis of the activity. And systemic inflammatory response not always correlates with what exactly is happening in the vessel wall. And low level of evidence compared to what's happening in atherosclerosis, because the results are usually from the open studies, case series, and expert opinion. And since it's a rare disease and a lack of ideal outcome measures are, there are no ideal outcome measures for this disease. So the first problem is immunosuppression might not be enough. There might be considerable risk of relapse, especially when tapering steroids. So there is something called as a refractory disease, defined as an increased disease activity following the reduction of corticosteroid dose or persisted despite use of at least one conventional immunosuppressive agents. These are one of the definition by the Turkish Takayasu arthritis study, and the possible solution might be disease-modifying agents or biological agents like methotrexate, azathioprine, or cyclophosphamide and MMF, and in biologics, it's infliximab and tocilizumab. So this is the flow chart in how to go about the medical management of patients with Takayasu arthritis or aortic arthritis. So some of the questions which arise while dealing with these patients of intervention in aortic arthritis is, should you do angioplasty when ESR is right, immunosuppressive treatment pre and post operation? What about if the patient is in failure? Do angioplasty if severe renal or thoracoabdominal aorta stenosis is there, or heart failure, whether heart failure is going to improve after intervening in these patients. Believe me, whenever you have raised ESR but no other signs of active inflammation going on, you can intervene with immunosuppressive treatment pre and post operation. And what our observation shows that is intervention in these patients help definitely improve in heart failure symptoms as well as ejection fraction. So balloon angioplasty is less invasive than vascular surgery but has limited data compared to vascular surgery, and success rate and outcome depends upon the site of stenosis, length of the stenosis, and stage of the disease. We had a very good initial success of nearly 90 to 100% and restenosis rate of only around 13 to 23%. Many of the lesions are densely fibrotic and resistant to dilatation. So this one has to keep in mind because these lesions don't usually give way that easily. These are some of the series from our institute, which was published way back in 1987, 92, and 94. One of the good armamentarium in treatment of this patient is cutting balloon angioplasty, who give controlled cut and more predictable results compared to facilitated, and it helps in facilitated dilatation with very less trauma to the vessel wall. So this is one of the example of only bilateral renal artery stenosis. One was 100, the other one had barely any flow. So this was cutting balloon angioplasty with 4 into 10 millimeters cutting balloon, and we have almost as good as a stent-like result in the right renal artery. Coming to the other important thing is stent implantation. The problems are, first I would like to tell you about the use of stents. This use of stents in these patients usually is indicated only when there is significant vascular recoil or there is flow limiting dissections. It has a very high immediate success rate or minimal procedural complications and restenosis rate of around 20%. So this is some of the series from our institute where we had fairly good results with stents. But the word of caution here is these promising results from Asian countries we have not been able to reproduce these results from other studies from different parts of the world where restenosis rate were as high as 50 to 75%. So coming to the relatively less involved vessels like pulmonary arteries and renal and coronary arteries, which are involved usually in around 5 to 15% of the patients of aortic arteritis. We had one publication of stenting of right pulmonary artery, which was dealt with a peripheral balloon expanding stent with fairly decent result. And this was the coronary angioplasty done of left main ostial stenosis using one drug-eluting stent of 4 into 12 millimeters Zions prime stent and post-dilated with 5 into 8 millimeters NC balloon. Sometimes we are seeing patients who are really unfortunate that endovascular treatment may be the only option. For example, this lady who had severe episodes of syncope and seizures for last 10 days before she came to us had a bald aortic arch. So reconstructing one of the arch and starting flow into the cerebral circulation using one limb of cerebral arch can help definitely in such kind of patients, where she had relatively improved. She improved in the form of no syncope for the next few years. And this is another case, something similar to it. Unlike coronary arteries, the peripheral arteries are known to have significant bends and other things in this patient. In this patient, you can see that the right brachiocephalic had a significant bend in the origin of the right common carotid artery. So this is how we did this wiring, which looks difficult, and once it is there, then it's very easy to do it. With the help of the buddy wire and the balloon inside the common carotid artery, one more wire was passed so that the loop in the brachiocephalic is reduced, and the procedure was done using a V-stenting in common carotid and vertebral artery, so that we had a good limb, one of the limb of the cerebral circulation, which can give collaterals to the other part of the brain. We had some series where the patients who had lost vision because of Takayasu arteritis with almost minimal blood flow to the eyes as well as the brain, doing intervention in one such artery has helped in restoration of the cases, restoration of vision as illustrated in this series. In this case, sometimes it not only involves the branch arteries, it also involves the arteries of the abdomen. As you can see here, there is no artery of the gut, which is almost all the arteries are 100%. We were able to wire the superior mesenteric artery and dilate it with a cutting balloon, and this is what the result we had at the end of cutting balloon angioplasty, so that almost all the vessels are being filled by opening just one superior mesenteric artery. Then again, many times it is not because of the disease as such, but it is iatrogenic sometimes. So this was a case where we did a bifurcation stenting of carotid and subclavian on the right side. So at the end of 1 month, patient had a minimal. He had started to develop claudication in the right upper limb. When we saw the pulse, we hardly felt any pulse on the right side. So then again we checked the prior angiogram, which is shown in the middle. As you can clearly see, while injecting the dye in the brachiocephalic artery, you can see that there is a guide-induced dissection to the lateral aspect of brachiocephalic artery, which was, we had earlier seen it, but we thought since it was non-flow limiting, we just left it like that. And once we came to know about this, once the patient presented to us with symptoms of insufficiency, we had to intervene, and we did direct balloon stenting of the right brachiocephalic artery. So interventions, it's important to assess the disease activity in this subset of patients, so that the treatment is tailor-made for those patients. Biologically targeted treatment can be tried in treatment-resistant patients who are already on immunosuppressive therapy. Percutaneous interventions in this patient is safe and effective, but we need more results, more trials to know about the safety and efficacy of this, and for the long-term results. Results are better for short-term, short segment disease, but not so for long segment disease. Cutting balloon angioplasty may help in ameliorating the use of stents in this group of patients, especially in young children, where you are expected the artery to grow as they grow up. Stent implantation may be a useful adjunct for vessel recoil or an flow limiting dissection. Sometimes this may be the only modality of treatment in the later stages of vascular disease. Thank you.
A question from the moderators, if possible. Question? Yeah, Dr. Girish sir, your views on the use of drug-eluting balloons in aortoarteritis?
Yeah, we have started using it, but we have started even drug-eluting stents too in aortoarteritis. But the results are not as good as even bare metal stents also. It's as high as around 50%. Especially because we don't have, the balloon size is not there. Peripheral balloons, yes, we can try to use. Peripheral drug-eluting balloons.
See, I would like to add one comment. As far as the stenosis after the stenting is concerned, it's important to remember the renal artery is much, much more prone to restenosis vis-a-vis aorta or arch vessels. It's rather 6 times more prone to restenosis. So we must do stenting only if we have to in the renal arteries. So this restenosis is much higher. Yeah. So there we can use
Catic balloon. Yeah, when drug-eluting peripheral balloon can be used, but since we had few cases on drug-eluting stents in renal artery, but the results are pretty bad.
We
are not
also
encouraging
using
at all.
cutting balloons for the renal artery, and we hardly, I mean, we try to
Yeah,
avoid the stent as
right,
much
you
as
are right.
possible, yeah.
Actually, if you expose these vessels surgically, as we have done as vascular surgeons, you really are surprised at how the stents can work in those situations. Because the lesions are so hard, especially I'm talking of the smaller vessels, not the aorta. But these vessels, sometimes it's very, very difficult that stents will work for them.
I think
See,
they've
our
run out of
patients
time.
are-
Yeah.
Yeah. The patients are as young as 5 years.
Yes,
And, So we do not actually aim for a optimal result. So a suboptimal result with a reasonable amount of opening up and less than 50% restenosis, we leave it at that. And the patients usually, they come back for the DSA or a CT angio, and we follow those ups. So it's not, so we don't aim for a total good result for post the angioplasty, especially in young patients who are active.
Thank you very much for that presentation, and I'll invite Dr. B.C. Srinivas to speak on venous interventions. Dr. Srinivas is very well known for his venous interventional work, and this has been going on for probably 2 decades. So, Dr. Srinivas.
Thank you, Dr. George. Good afternoon, friends. Next. I think venous intervention should be taken up by interventional cardiologists, because by the virtue of your techniques, which are very well versed for you. Next slide. By the virtue of knowing the technique of angioplasty well compared to other medical specialties, I think venous diseases should be taken up by cardiologists, I personally feel. So these are the situations where you can intervene and give lasting relief. For example, I'll go through a series of cases so that you can see how you can identify these cases and do these cases. This is a typical web in the IVC. This can be treated easily with a balloon angioplasty, and you can give lasting relief. For example, in this case, you can see a simple equipment like a Mullin sheath and a thermowire. We have been able to cross it. Once you cross it, you can use the hardware which is available with you. In fact, Acura balloon or Inouye balloon is ideally suited to treat a IVC web because it locks against the membrane well and ruptures the membrane well. You can see, you get a great result like this. Generally, I leave them alone when I get a result like that. On table, you can see that the veins decompress immediately. And then some of them do restenose. You need to follow them up. This guy restenose 3 months later. This is a situation where we stent it and give a lasting relief. Now, some patients of this need sharp recanalization to cross. For example, here, you can see this is actually failed twice, referred to us from 1996, 2008. This was done about 5 years ago, long segment. This is a typical case where it needs a long, sharp recanalization technique. This is actually, it is a Mullin sheath to stabilize against the lesion, and the hard end of the termo is crossed. So then the technique is the same. You need to stent them, okay, to give lasting relief, okay. This is an example of a sharp recanalization with a broken bone. Here, the morphology was suitable to come from the internal jugular rather than from the femoral vein. So here what we have done, we have come from the internal jugular vein with the pediatric broken bone needle Mullin sheath assembly, maneuvered through the upper portion of the occlusion, and then we have crossed that, and once we cross that, then the next steps are the similar. So you give them real long relief. But you have to be careful. You need to study and look at the, if you have a clot like this in the IVC, if you dilate that web, then you are in trouble. Then the patient can have a massive pulmonary emboli. This is a situation where you do a catheter-directed thrombolysis below the level of obstruction, and then clear the clot. And then if there are residual clot, you can just trap it with a stent, self-expanding stent, and then treat them. So you need to modify, you study them and modify according to the situation. And nearly 70 to 80% of them have associated hepatic vein involvement. You need to definitely look at that. In this case, you can see that there is a web at the IVC hepatic vein junction that you need to treat to give relief. In this case, it was stented. Even the IVC was stented. And you can see the ascites in a week's time resolves. So this is again another hepatic venous outflow obstruction where the hepatic veins were completely occluded. In this case, you cannot come from the IVC end. So what we do, percutaneously transhepatic, you enter the hepatic vein through ultrasound guided puncture, and then introduce the sheath into the hepatic vein through the liver tissue, and then cross this. In this case, it was a sharp recanalization done with a Chiba needle. And then once you cross into the IVC, then you actually you pass a wire and then snare it out, and the rest of the things are same. So you stent it. So another example here again, previously stented right hepatic vein is also occluded, which you could not recanalize. But there was a very good middle hepatic vein, which we have, what we did was we just crossed with a broken bone needle, sharp recanalization done, and then you pass a wire and then snare it out either from the femoral or from the jugular and complete the procedure with a angioplasty and stent implantation. These techniques actually you can modify on table according to the situation. And most of you are aware of these techniques. So you can adapt them. Another set of diseases is the central venous occlusions. You see this moribund disease because so many CKD patients are coming with central vein stenosis with upper limb venous hypertension. This you can relieve, but CT forms an important methodology to properly assess the block, the lesion, and then you do the intervention according to the situation. Now, in this case, it's a stenosis of the left innominate vein. You can give a good relief with a balloon. This is an Atlas balloon, 14 into 40. It's a non-compliant balloon from Bard, which heals these lesions well. And you can see, when you get a lesion like this, when you get a result like this, you can just leave it alone. You don't need to stent. This was actually, it was a left fistula which got infected, amputation done, right fistula done, even that, he developed a central vein occlusion in the right subclavian in the innominate with right upper limb venous hypertension. So it was a very long segment. So this you can see, we have an antegrade and retrograde approach. We access the axillary vein, and using a Cook's catheter and a termo, straight termo, we could cross through, and then that wire was snared out from the femoral vein, and then we did the intervention from the femoral venous approach. That is the pre-dilatation of the occlusion, and then we actually stented the lesion. So you get great results like this, which are well maintained. Nearly 50 to 60% of them can come with restenosis, but you should be ready to treat the restenosis. I'll show another example. This was a great case about, in fact, 19 years duration of the upper body swelling, and you can see this is SVC is occluded, right subclavian innominate vein till SVC is occluded, left innominate into SVC is occluded. So we had to recanalize from SVC into both arms. So what we did, we started with the right subclavian venous approach, but we ended up in a false lumen. So then we came back from the femoral, so through a sheath, you can see that actually helped us to pass the wire across the occlusion, and that was grabbed from the left subclavian venous approach. And then we had the veno-venous loop between the left upper limb and the right femoral vein. So that we used and created a track using serial balloon dilatation, finally Atlas balloon. And then we had the, so we had the left open now, left innominate into SVC. So we had to connect the right subclavian
through innominate vein into the SPC. So that we achieved by using a broken bone needle. You can see here, actually first attempt we failed, second attempt we could succeed. So again, serial balloon dilatation. So we got the right also open. So now we had both the upper limb venous output into the SPC open. So that we did actually, you can see that there is two wall stents coming in from both the innominate veins into the SPC. So we reconstructed both the innominate veins into the SPC. So you can give good relief, and most important, next day edema resolved. This is, I'm talking of 19 years of edema, decreased vision, headache, which disappeared in 24 hours. That's the beauty of venous interventions. So similar, you can have combination. We had an IVC occlusion plus a central venous occlusion. So we treated both the IVC as well as the central vein and relieved both. Again, this needed a sharp recanalization with a broken bone needle to cross the central venous occlusion. So that is IVC which is open, and then the right innominate vein also is open. That is a wall stent in place post-angioplasty. So this, again, SPC syndrome, again in a CKD patient, this SPC is occluded, you can see here. Even if you recanalize from one innominate vein into SPC, like we did in this case, the symptom relief is very remarkable. You see this, okay, we put in one single stent from left innominate into SPC, but you see the relief of, for the patient, it is very remarkable. So another subset where you can help this patient is the DVT. Proximal DVTs, where there is extensive thrombosis. For example, I'll show you this case. This was a 22-year-old guy post motorcycle accident because of immobilization for a week, developed extensive thrombosis, right iliac all the way up to the renal veins, IVC, and then entire left leg above the tibial veins was occluded with thrombus. So this clearly needs a pharmacomechanical approach. We have good catheters now, like Penumbra, where you can aspirate the catheter. But this, at that particular time, when I did this, it was done with a 8F JR guiding catheter. So this is the aspirated clot. And then we lyse with a catheter-directed thrombolysis, both in, actually first from the right, second from the left, and you can recanalize the entire thing. Okay. Okay. To conclude, you can incorporate your technical skills of balloon angioplasty and stent implantation to treat many venous diseases. There, in fact, okay, I'd like to show two more cases here. One is the chronic venous insufficiency, because the one of the main problems is the DVT is undertreated or untreated. So untreated, undertreated can DVT can present with chronic venous insufficiency. For example, this case, this is a very typical chronic venous insufficiency. This is how it appears. But this can be treated well with PT and stent implantation. You can see that we can reconstruct the veins like this in the pelvic venous outflow. And then what happens is the wounds heal so rapidly. Just another case I'll show. That's the last case. This was, you can see, this was 8 years non-healing ulcer, large ulcer due to venous insufficiency. Both iliac veins and IVCs occluded. That is the kind of wound you have. And we balloon dilate, and then actually from both femoral venous approach, we reconstructed both the iliac veins into IVC, and that is, okay, that is post-reconstruction of both iliac veins into IVC. And what happens, you see the result clinically. Third day, the wound heals. 8 years old wound heals on third day. That is what you achieve. So I think choosing your cases properly and treating them appropriately will help them. So I think it should become a part of our interventional practice, I feel. Thank you.
Thank you, Dr. Srinivas, for that overview of venous interventions and what all is possible, and encouraging cardiologists to venture into this field. Any questions from panelists? If not, I'll invite Dr. Rajiv Parak, a vascular surgeon from Gurgaon, to talk on aortic interventions.
Thank you, Chairman. Okay, so
aortic intervention in 10 minutes. I think it's a bit of a tall order. But anyway, I think you saw the top end and the top end of the spectrum when George showed you all the high-end stuff that can be done. I'm going to try and take you through some very basic stuff with complications and with procedures and how to get through with them. So these are the aortic interventions that we do perform at the Medanta Medicity Hospital in Gurgaon in Delhi. This is the standard repair as vascular surgeons repair, or the open repair of aortic aneurysms, and this used to be a very bloody repair. It still is, and that's the kind of end result once a patient comes through. And this, of course, is replaced, being increasingly replaced with endovascular options. And you can see patient goes home with just these groin exposures. And of course, with the endovascular repair, with the closure devices available, the ProGlide especially, we are actually able to actually do what are called PVARs, which are percutaneous endovascular repairs, and the patient can actually literally get up and walk away almost the next day. So that is exactly how that works. So it is a possibility, it is endovascular repair as a day case is actually becoming and is becoming a day case reality. So I'm going to try and take you through some very, very cases. This was a 61-year-old female with diabetic coronary artery disease with absent femoral and distal pulses. She did give previous history of having had an abdominal aortic aneurysm. So on examination, of course, what we saw was a thrombosed aortic aneurysm. This was completely thrombosed, and this obviously needed either an intervention or an open surgical procedure. So we decided to actually try and recanalize this whole thing. So we came from above and snared up a wire from the groin, and here you can see that. And this was then completed with using a aortouniiliac graft with an a femorofemoral approach using these two punctures, which is the brachial in the left groin in the hybrid OR that we have. So this patient, we actually, once the wires were crossed, then we did serial balloon dilatations, and that was subsequently lined with the uniiliac device, followed by the femorofemoral crossover. And here you can see the completion angiogram. There is no endoleak anywhere, and this patient actually walked out very easily within 3 to 5 days. The next case is a 75-year-old obese female who came to us with breathlessness and severe chest pain, and on a late Saturday evening, she had a large a leaking thoracic aortic aneurysm, and this had actually gone through into her chest, and you can see that there is a compression of the lungs, so she was grossly dyspneic because of the hemothorax that had actually occurred. She had very difficult access. Now, this is something that we really need to plan the access whenever you're planning any endovascular procedure, especially when you're going to take up huge devices and other things. So this is something which needs to be done. There is no way that you're going to be able to take any device through that. So what we do is, there is no way that you can come from above either. So here, what we actually did was to pave and crack the backside, which is from below. So this is actually trying to come up the retrograde route by paving and cracking the back end. So here we actually, the way to tackle these difficult arterial accesses is to actually pave the internal iliac artery, dilate the common iliac and the external iliac, and do balloon dilatations with fluency and line them with fluency endografts, and then take your device up through that and open that device up, the first device and the extension device, and eventually then do a balloon dilatation and close that off. In this particular case, there was a further stenosis which we realized, which was further downstream, as you can see here. So this patient had required another endograft, which had to actually go beyond the original entry site, and this was then lined by the fluency and of course reinforced by using a PTFE graft and a TachoSeal just to make sure that there is going to be no leak, and that of course was the procedure that was carried out. You do sometimes come across with common iliac artery aneurysms. We had this patient with bilateral internal internal iliac artery aneurysm, which were treated by using the IBD devices from Cook. Here you can see that basically you're trying to, just simulate or think of the internal iliac aneurysm as an aortic aneurysm and actually treat it the same way as you would by taking up a wire, putting in pigtails over the stiff wires, dilating them, opening up the stent graft, and then lining them, continuing them with either using a Fluency or a Bentley extension into the internal iliacs and opening up this stent graft into the internal iliac artery. As you can see here, this is the completion angiogram after the balloon dilatation into the internal iliac artery, and this is the final flow through when the internal iliacs are excluded. Sometimes we come across very, very tortuous anatomy, and it's extremely difficult to try and avoid an endoleak. Here you can see we have placed the device and there is an endoleak, and here you can see, so that, to avoid to cover the endoleak, we placed a covered Palmer's a CP stent, and there you can see that has been placed and the endoleak is finally resolved. So if there is an angulation at an area at the aortic neck, then this is again a bailout option in which this can do. So the future, all this requires a huge amount of radiation, a huge amount of contrast. So the future there in radiology is that of diffusion imaging. You can actually superimpose and overlay the CT images as the patient's on the table, and you can actually then draw out what are going to be your access sites and the areas of interest in the arteries, the renals, or the superior mesenterics, wherever you can. And this can be used to cannulate these arteries without the use of repeated contrast injections or radiation. And of course, going beyond the boundaries, some of them have actually been touched upon by George, and this is again an aortic arch which is completely debranched. As you can see, this has been done here, and you can see that the innominate has been stitched on to a 10 millimeter Dacron. The left carotid has been stitched on to the side of this, and then of course the subclavian artery you can see at the end, in the extreme corner, been done to go beyond the boundaries, in which this is the final result. You can see that the aneurysm has been sealed in zone 0. So that is an area which is difficult to get into, and this is what we alluded to when George was talking about that you would replace the valve and the coronaries, and of course do endografts to come down through both the carotids and actually do a complete endo procedure without any interventions, a percutaneous aortic valve, coronary inserts, ascending, and neuroprotection devices, and a special stent to correct the clink. So this is essentially what it is. In a nutshell, I thought the most important thing is to have a aortic aneurysm response team. When an aneurysm arrives in the casualty, I think there has to be people who have to be like-minded people, ready to get on and do the job, get a CT angio, shift the patient to the OR. You have to have all the relevant, the devices available on shelf, or at least as many as you can, and be able to, put the team together and be able to conduct whatever is required to be done. So thank you very much. The privilege of the podium.
Any comments from anyone? Thank you, Rajiv, for that overview of aortic interventions and the team that you have got together for the acute aortic work. Now I'll invite Dr. Bedi, last speaker, but by no means the least, to give us an overview on lower limb ischemia.
Yeah. Thanks very much, George, for the kind introduction. And now back to some fantastic work shown out here by some fantastic guys out here. And I'm just going to come down to bread and butter issues for vascular surgeons. Talking about limb ischemia, what exactly is PAOD? So I'll skip through some of these basic slides which are there, and all. Of course, what is a claudicants, what is the natural history? Of course, many of them do have coronary artery disease, cerebrovascular disease, and management. Of course, besides the exercise part, you have to consider looking at interventions in many of these patients. And today, of course, there has been a defining moment in the sense that there's some new papers that have come up, and now we have a global vascular guidelines which have come up in terms of defining the targeted approach, what has been replaced, the chronic limb ischemia or the critical limb ischemia has been replaced by the CLTI term. And then accordingly, what today we are looking at is more in terms of evidence-based management rather than looking at only just treating lesions. So I think this is what the future is in the CLTI, the Global Vascular Guidelines addresses that to a large extent. So I'll just show some cases in all. A 60-year-old male, diabetic coronary artery disease, post-PTCA, wet gangrene, and I can warn you that I'm going to show some dirty pictures out here of wounds, correcting. With a duplex BTK disease, and this is the kind of wound which was there when patient came out here. He was in sepsis, post-amputation. There was some, lot of muck out there. It wasn't a very good bleeding and all from the wound. And when you look at the disease, you find that patient has got below the knee multiple occlusions of the vessels in this case. So antegrade from contralateral side, we could not really cross, and then we had to do a retrograde access as we are doing. We are puncturing at the dorsal spinatus artery. And once you got your wire inside with a micropuncture needle, you make your way up there. And then after that, you snare the wire from top, because all interventions are done from top only, from the contralateral side. And then you get your balloon across. You do a wire flossing with the balloon out here. And as you can see, once we're doing this ballooning out here, you can see them stenotic segments out there. And you got a fantastic result after that in terms of good runoff into the toes out here. So this is the kind of thing that today we are doing in terms of doing antegrade, retrograde, all kinds of accesses out here. And you look at the final result of the wound here, you have nice red granulation tissue as compared to what was there previously, and covered it up with a skin graft. Case number 2, a 65 male diabetic with low ejection fraction, 25%, non-healing wound over plantar aspect of foot for 1 month, and dirty slough over the plantar wound with necrotic patches out here. And duplex showed a distal SFA and popliteal occlusion. So when you look at it, you find the popliteal is totally occluded, and you see reformation of one vessel out here. Went across, crossed the lesion from here, doing an angioplasty with a balloon. And then after that, you see there is still some bit of a residual dissection out there or disease. So in this case, of course, putting in a Supera stent, a vasculomimetic stent out here. This is the only stent which is indicated, and you get a fantastic runoff down below the knee, and you bend the knee also, and you find that the stent does not really get bent. So this is probably the only stent which can be used, and this successfully helps us in revascularization, and post-angioplasty with dressings and all, the wounds heal rapidly. And this is what the final outcome of this patient is. Case 3 in intravascular, this was the first time during our endovascular live meeting we showed this patient. A shockwave lithoplasty, lithotripsy was done for critical limb ischemia. You had a balloon in the distal SFA popliteal segment, and we inflated this balloon out here at translumina, and now this is being used in the coronaries also, and did an ATA DP, at the DP angioplasty out here. And once you had that, you got good runoff into the wound, into the foot. Case number 4, 58-year-old female, uncontrolled diabetes again, with the ejection fraction of 35%, severe foot sepsis, dry gangrene, bilateral iliacs were occluded, and this is the wound which was there initially. We did a CO2 angiography, we did an angiography out here, and as you can find out here, the iliac, right iliac occluded, left iliac occluded, both the common iliacs are occluded out here, and then you can see the aortic bifurcation from top. So these are the places where we deploy kissing stents from both the sides, get across access either from the brachial into the femoral, and then reverse them. And here you have a final angiogram, a good result out here in terms of wound management. And this patient post-plasty, the wound has been we've been able to close the wound primarily. Case number 5, 60-year-old male diabetic, foul-smelling foot, and this probably, I think 9 out of 10 people in this room, or even a physician for that matter, would straight away send him for a below-knee amputation. Am I right? So anyway, they are not any vascular surgeons, so I think most of them would consider subjecting this patient to an amputation where a patient has got multi-level disease. You got an SFA stenosis, then you have down below ATA lesion, below the knee, you have lesions out there. And down below again you have a diffuse ATA disease, and you have the PTA also gone. So here we started off basically crossing out there and then doing angioplasty with long balloons across all the origins, doing an SFA angioplasty, and you have the final correction all the level of diseases, whatever are there, and you have one vessel run off into the foot, which is now looking pretty good. And post-angioplasty, this is what the wound looks like, and then treating it with VAC and Veraflow with colistin and all that. 4 sessions of VAC, and subsequently this is what the wound looks like. So this patient 9 out of 10 times would have probably gone for a below-knee amputation, and this is what we can do. Sometimes you do have to end up doing hybrid procedures out here where patients have multiple level disease, right, CIA lesion, CFA lesion, 90% calcific plaque, and again SFA lesion out there. And here what we do is, there's a right CIA EIA stenosis out here. We did an endarterectomy, removed the plaque from the CFA, PFA, and this thing, and then we go retrograde from the groin exposure only, getting across, doing a ballooning. Once you do the ballooning out here, you do a vein patch closure of the wound. Then after that, you address the iliac lesion on top, you put in stents into the iliac artery, and this is what the final result is. You got straight line flow all the way going from the iliacs down into the complete leg down below. Just to show a couple of more cases, acute limb ischemia. Today, of course, a lot of these patients come to cardiologists also for that matter with acute limb ischemia. So what can be done? A 70-year-old male, 5th toe spreading gangrene, 4 days with atrial fibrillation, popliteal and BTK, you had acute thrombosis, the foot is cold, and this is what the wound looks like. So emergency, when the patient comes in sepsis, you do a debrima, offload, and then after that, today, I think this is the age where you do only fluoroscopic assisted popliteal and tibial thrombectomies, you do embolectomy out there. Try to go across into each of these vessels, and as you can see, this Fogarty is out here going across into the posterior tibial artery. Remove the clot from each one of these vessels because you don't want to lose any bit of vessel out there or tissue for that matter. Once you have good runoff out here, and this is what the wound looks like, it becomes nicely red, and you can skin graft this wound, and after that the wound heals. Another patient with right foot cyanosis, spreading gangrene since 2 days, SFA thrombosis over calcific plaque, acute on chronic occlusion. So many a times you find that there is a SFA thrombosis out here. You do a Fogarty embolectomy, and then after that you find that there's an indentation out there in the Fogarty. That means there is definitely a ruptured plaque which has been there, and this lesion is unmasked. You clear out the thrombus. After that you put in a stent out there in these situations, and you get a fantastic wound which goes across, right across. You have a blood flow across into the foot. And this wound, 15 days post-op, the gangrene is nicely demarcated, and then 4 months later, after removing the forefoot, the wound has healed. So we've been able to avoid a forefoot gangrene. Another case with occluded bilateral iliac stent with cool lower limbs, class 2A Rutherford out here, and you can see there's a total flush occlusion out here. And this is probably something people would subject for doing open surgery in this case. But here we thrombolized this patient, and after that we did a balloon, cleaned up the clots and all. Out here you can see some residual lesion out here in the left iliac, and then you stent that particular lesion. Sorry, that image was, anyway. So we cleared off all that, and we had some, can we play this angio please? Oh no, okay. So anyway, so the take home message is the leg is often taken lightly. Amputations are being done when the legs could have been saved. Many a leg of these patients could have been saved. The physical and the psychological impact of a major amputation are underestimated. Not every septic foot needs a major amputation. We have salvaged many. I think all of our colleagues also would have done many of them. And vascular disease can often be corrected, and that too using minimally invasive techniques, thereby achieving limb salvage as illustrated in the cases described above. I thank you for your patient listening, and this is my team from Vedanta. And the extended team which is there, a lot of participants who are there, Dr. George, Dr. B.C. Srinivas, and many others. We have the largest meeting in the world of endovascular live coming up again next year. We just finished this a few weeks back, and Dr. Rajiv Parakh, of course, is there. And thank you so much.
Thank you, Dr. Bedi, for that excellent overview of limb ischemia and how you manage it. Do you have a team other than interventionalists like, foot care, podiatrists, diabetologists, follow-up nurses? Do you need all that too?
Yes, absolutely. In fact, that's very, very important that you must have a full team. We have a diabetic foot care center run by one of the vascular surgeons. Of course, he devotes himself completely to that part. Along with that, we do have nurses we have vascular counselors, we have nurses, we have trained staff, diabetic foot care technicians, who basically assist us in managing all the wounds. So I think, and of course, a part of our team is the endocrinologist who is there, the plastic surgeon who is an integral part of the team. So it has to be a multidisciplinary kind of a team for managing these diabetic foot, because that is the biggest challenge out there. Yeah.
There's a question.
Yeah. Reperfusion and all that. See, that is what's very important, that when you revascularize also at the same time, if required, if it's a wet gangrene, then in that case you are going to basically excise that part and all. As I showed first of my cases out here, many of these patients we tend to offload. If it's a dry gangrene, then you can wait because that part is never really going to get blood. But whenever there's wet gangrene and all, then we try to remove whatever is the infected portion out there. Correct. No, you can do it at the same sitting. It doesn't have to be that you have to do immediately, but yes, when you have basically a compartment syndrome in the legs and all, then in that case, before revascularization, you're going to do a fasciotomy and all in those patients. Yeah.
Thank you. That brings us to the end of this session. I thank all the speakers, the moderators, participants, and good afternoon.
Thank you.